to So there we go. A very good evening to everyone again. And it is a pleasure indeed to be back in the virtual medium to be able to communicate with you on what I would definitely call the flavor of the week gone by. We know that we've had the World Congenital Heart Defect Awareness Day. And so we have our very own symposium at the Society of Fetal Medicine for this. In the week gone by, there has been a tendency to try and make the world aware of the fact that, yes, indeed, there is this major hassle, as we call it, or like we should be calling it, that, yes, indeed, we have a problem here. Are you able to see my presentation?
Yes, sir. Yes, sir.
Wonderful. And you see, what we're trying to bring about on our part at the Society of Fetal Medicine is an awareness of what should be going on. And so we thought we'll put together things that are not run of the mill, but something that is important for you and me, and that is to handle what is referred to very crudely as the burden of congenital heart disease. No human disease should ever be looked upon as a burden, but for some reason, the March of Dimes has given a lot of things this. We have the burden of aneuploidies, we have the burden of what is referred to as things like Down syndrome, etc. But we do realize that, yes, there is a problem, particularly with these. There is a situation where families face a lot of problem and angst, and individuals face a lot of problem and angst, because cardiac anomalies are now becoming more and more common, particularly with the specter of neural tube defects fading away. And we realize that, some of the simpler ones are not so important, but the really significant ones can be fairly high, which is between 4 to 8 or maybe even 10 per thousand live births, depending on the population you're looking at. And we need to do something about this. Mostly because pregnancies with anomalous fetal hearts benefit a lot from skilled and specialized antenatal and neonatal care. And the outcome of these does not necessarily have to be tragic. And something can be done about it. And this is what we hope to discuss today and make everybody aware. As usual, we will put this onto our SFM YouTube channel so that you're able to see that, and it will be there for posterity for people to understand. The other thing that we do realize is that if you have a high-risk patient, and we will discuss these today, for cardiac anomalies, they will benefit from a good antenatal ultrasound scan, which is targeted at either confirming congenital heart disease or excluding congenital heart disease. And that becomes important because we've known for several years now, and this paper that I've put up here on this slide is 8 years old, where we did realize that if you have an antenatal diagnosis, then there is definitely a much better outcome of that pregnancy in the neonatal phase. And therefore, we will take you through some of these things, including the understanding of protocols, for which Dr. Bimal Sani will take us through, and talk about optimizing cardiac evaluation daily practice. We will also have a talk that covers screening of congenital heart defects and the indications, etc., followed by a panel discussion. But what we really want to emphasize is that, look, there's about 1.3 million children who are born with congenital heart defects annually. And the figure has remained constant only because a lot of patients end up with terminating some of these pregnancies. Otherwise, it would have really swelled up. The other thing is that 80 to 90% of these would be in patients who actually have no risk factor. And we must realize that group, therefore, is the general patient, and therefore every anomaly scan has to have some degree of cardiac evaluation, and we will see what is optimal. And again, that is part of the talks we're going to hear today. We also realize that the detection rate remains poor, and we hope we have some answers to that. And of course, we have clinicians on board. We have on our panel Dr. Balaganesh, who is a fetal cardiologist. We have Dr. Ratnapuri, our former president, who is one of the most patient-friendly geneticists you will ever come across. We have Dr. UP Singh from Chandigarh, who is also a pediatric cardiologist. We have Dr. Chinmay Rath, who's on the panel, who is extremely well known for her completely overwhelming and perfect approach to the patient who has a so-called fetal medicine problem, because we need to handle not just imaging, but we need to handle genetics, but a lot more even after that. So that's what we will be doing. And then, of course, for our inputs, Dr. Alok Varshni will talk about imaging, and everything will be guided by Dr. Vandana Bansal, who is our moderator. What we hope to discuss during the course of the evening today is the fact that we need to impart skills and how we're going to do so. And we're doing this quite successfully in Society of Fetal Medicine. We're going to provide you working protocols. And also my appeal then would be that most of us should actually follow these protocols and these checklists, because we will be able to then use them appropriately. We must then make sure that after a diagnosis, we have appropriate antenatal management and maternal and family support. For this, we need personnel, we need technology, both imaging as well as genetics, and management algorithms. And we know that today, this evening, we're going to be able to put together a whole lot of things on this, and that should be a good carry-home message. We also want to see our country transformed into promoting the development of centers that can manage the neonate or the infant or the child with congenital heart disease. Yes, some of this depends on government policy, depends on national policy, depends on the amount of budget that the government gives us for health. We do know that this is tragically lacking, and we hope to sensitize those that matter, policymakers, the PM's office and so on, the health ministers of states as well as at the center, to make sure that such centers do come up, not just in the private world where it seems to be emerging today, but centers also in every medical college, so that we can have this without too much of a distance. We need to take skills to the people. We need to make sure that it becomes available as close to people's homes as possible. And therefore, this becomes government responsibility. But I think as an individual involved with healthcare, all of us need to promote this in whatever way we can. We will also discuss that, yes, these things are expensive, but as national policy, again, we have to make sure that the governments of the states as well as at the center make the cost of care proportionate to the economic indices of the country, so that those patients who cannot afford such care should get this care free of cost at the cost of the state. Part of this can be met by insurance plans. We know we have some in place, but unfortunately, the people who need it the most have no insurance plans, and they depend completely on care that is available in medical colleges and government hospitals. Unfortunately, we don't have enough budgeting in most of those to cover the requirement that we have. And so towards the end, and I think during the panel, we will also discuss this. So what we hope that we will take you today is all of this: sensitize ourselves, make sure that we get enough information, and put this then on social media as well as on YouTube, so that everybody gets to see this. So over now to our activities for the day, and it gives me great pleasure to have our National President, Dr. Bimal Sani, presenting Optimizing Cardiac Evaluation in Daily Practice. Over to you, Bimal.
Thank you very much, sir. And you've set the tone for the meeting today, because that's the kind of message we're trying to give, because this is a CHD Awareness Week, and you really brought out that how by it's not just about making a diagnosis prenatally, but then yes, if we have centers where a good cardiac surgeries, pediatric management can be done, automatically it's really going to help, and it becomes our moral duty then to guide the patient and inform them that yes, because there are quite a few cardiac anomalies which now can be managed and treated very well, and these babies can have very good outcomes. Now, I'm going to take you through optimizing cardiac evaluation in daily practice. Cardiac evaluation. sir has already said, but why is it so important? It has a very, very high incidence. We know that a prenatal diagnosis of a complex CHD at the right time gives an option to the parents to terminate the pregnancy. Prenatal diagnosis allows delivery in a tertiary center. Very important, specifically when we are dealing with ductal dependent lesions, so that a prostaglandin infusion can be started to maintain ductal patency. And like sir said, postnatal surgical outcomes are far better in prenatally diagnosed cases. And then yes, we have a meta-analysis which tells definitely if a CHD has been diagnosed prenatally, the outcomes become better. And I think in most of the cases, this happens because then the patient knows there is a problem that may require immediate, and then they do end up delivering in a tertiary center where immediately you have specialists who take care of the baby. Now, cardiac evaluation actually has evolved. There was a time when, looking at the heart was whether the heart is beating or not. Then we move to a stage where the heart appears normal, or we could just say, okay, this heart doesn't look normal, there is something wrong with that. Then we move to closer to a precise diagnosis, or we could give a differential diagnosis. But now, yes, with the kind of machines that we have, with the kind of knowledge that has been dissipated, we are able in majority of the cases to make a precise diagnosis on what kind of a congenital heart defect this is. And then not just that, then fetal therapy, even with cardiac abnormalities, is something which is being done in some centers in the world. And yes, a few cases have been done in India also. The problem is that we need everybody to move on. There is still a major segment which is still lying into this bracket on, for them looking at the heart is just to look at the heartbeat or the heart rate. But we need a major segment which is dealing with this in this part, and then they all need to evolve into the steps that I spoke about. Now, despite the accuracy of fetal echo that we talk about, the second trimester detection of CHD is very low in the population at present. And I'm not talking about just in India, but all over the world, the overall detection rate is low, though we know that the potential is huge. Now, what is the solution for that? The solution is, first, I think the most important thing is that attention to anatomic details of the heart should be a part of every ultrasound examination. Everyone who's doing a mid-trimester scan needs to, for them looking at the heart should just not be, just looking at the four-chamber view or just grossly seeing whether the heart is beating well or not. They need to look at anatomic details. And for that, first and foremost, I just tell everybody that remove the phobia of the fetal heart. You need to remove this phobia. Because if you can look at the brain well, if you can look at the spine well, yes, if you put in some time, you will also be able to look at the heart well. And then the most important thing which Sir spoke about is to follow protocols. Now, good outcome. See, finally, what we are talking about, giving the baby a good outcome. A good outcome comes from correct diagnosis, and correct diagnosis comes from good imaging. And good imaging, for good imaging, you need image optimization and you need good presets. So four primarily thing in daily practice that you require for picking up a CHD. One is good preset optimization, good image optimization, systematic evaluation, that is what I was talking about, the protocols, and then pattern recognition. So if you follow these, so when we say presets, yes, you need to get your presets made. You need to have separate presets for the first trimester cardiac evaluation, separate preset for the mid trimester. We have presets for an obese patient also, and a separate preset for the third trimester. The color optimization, for the color optimization, again, you need to have a preset for flow across the AV valves, but you can't use the same thing for looking at the venous flow. So you need to have a separate preset for that, unless you are very good in making the changes while you are scanning. But then again, that is going to take you a lot of time. It is more easier to, from Like if I have already seen the flow across the AV valve and I want to look at the venous flow, it's more easy for me to move into a preset of the venous flow rather than make all the changes in the PRF and the balance. First trimester cardiac, important thing is color. Color, we all know that, yes, in the first trimester, the grayscale imaging of the heart is not that easy. Lot of information that we provide in the first trimester comes from the color flow, and hence the color settings in the first trimester are very important. Then, for the grayscale, there are certain tips that we need to follow: a narrow scan angle, reduce the depth, high frame rates, dynamic range. Then all these machines have such wonderful, fancy things like the harmonics, the CRI and SRI. They are not meant for no reason. Actually, you are supposed to use all this. And the most important part is image magnification, which most of us tend to circumvent, that we just want to look at the heart, in the whole screen you are seeing a tiny heart, and just try to make a diagnosis out of it. So the image magnification is a major part of that. And I'll just show you one or two examples. Here you have a native image which is showing it's a wide angle, no magnification, and when you magnify that with with a narrow angle, you look at the clarity that you're going to get from there. Then you have, as I talked about, the harmonics, the CRI and the SRI. Now this is a native image, but when I add CRI and SRI, you look at the clarity with which I am seeing that, and if I use tissue harmonics also, so you keep adding these fancy, people feel they're just fancy things just to make the image look good, but no, they are also, if the image looks good, you're going to end up making a good diagnosis. Color optimizing factors like the color gain, the color box, the size, PRF, power. I'm not getting into details about how you're going to do it, but then my essence of what I'm trying to take you through is that having these optimization is very, very important, because the color settings for a flow across the AV valves and the semilunar valves and then the venous is going to be different. And so like, you for the AV valves, you require the PRF high, the wall filter to be high, the persistence to be low, and the color gain to be low. Whereas for the pulmonary veins and the systemic veins, you require the color velocity to be low, the wall filter to be low, the persistence to be high, and the color gain to be high. So this, you can see that how there is a difference between the settings that you do for the AV valves and for the pulmonary and the systemic veins. Hence, the message till now is that you need to get your presets done. The other prerequisites for a good cardiac evaluation in daily practice is a friendly maternal abdominal wall. That unfortunately is becoming less and less in the last few years, because we know that the BMIs have gone up, and then with the advent of ART pregnancies and all those, a lot of them are with PCOD, they have a very, very thick maternal abdominal wall, and then you need a friendly fetus. Now, again, that again depends on the fetus, whether they really want to be friendly with us and they give you a good supine position, and that is required. But I'll just take you through 1 or 2 points as far as when you have a mother with a high BMI. Now, yes, I know you're going to write down a disclaimer that yes, there is limited viewing because of that, but then you need to eventually take pains to look at the heart. You need to, so there are some ways of doing it. You can, optimize the image window. You can take, or you move the window from where you are not getting. There are some areas like the periumbilical area, the iliac foci, where, or if you just go a little lateral where to the rectus muscle, you will get a good window from there. Or then in the suprapubic area, just above the symphysis pubis. But again, that becomes a little difficult if she's already had a previous cesarean section. And then you can use a full bladder technique, because you know from the periumbilical region you're going to get a good window, and you want to push the heart up in the, you know, in the maternal mid abdomen. You want it to come below the umbilicus, so you can use a full bladder technique for that. Or you can change the plane of section, use all available technical tools like harmonic, CRI and SRI, which I talked about. Or at times we do use the compression method also, where we, you know, we compress a bit so that the anterior abdominal layer becomes a little thinner, and you may still end up getting a decent image. And then you can use color in, you know, in all these cases where you put in color, maybe the color imaging part will give you a better, better visualization, and you are able to make a diagnosis there. So proper settings achieve optimized image, which leads to a precise diagnosis. That was the first 2 points that we have covered. Then we come down to, in daily practice, we need to follow protocols and guidelines. Now, there are protocols for basic screening, extended basic screening, and fetal echocardiography. Now, I'm not taking you through the guidelines because these are all available on you. So you can use the SFM guidelines, you can use the ISWA guidelines, you can use the AIUM guidelines. So you just need to download and you are going to get that. But what I'm trying to say is that this basic screening initially used to be just about looking at the 4-chamber view, but now we have the extended basic screening, which actually has become the basic screening. Now that is something which we do for evaluation of low-risk fetus as a part of routine prenatal care. And then we have fetal echocardiography, which has certain indications where you have patients with suspected cardiac anomalies, and those patients with certain risk factors. Now, such as maternal factors, increased NT, extra cardiac anomalies, IVF pregnancy. Now, these are all, or diabetes mellitus, these are all indications for a fetal echocardiography. But the most important indication is patients with suspected cardiac anomalies. Now, who's going to suspect this? Patient is not going to come and tell you that, oh, you know, I am suspected to have a cardiac anomaly, because that will go in these where there is a history or something. So as a part of your routine prenatal care, you are actually supposed to suspect that there is a cardiac anomaly and then put the patient through a fetal echocardiography if you're not able to make a precise diagnosis from the extended basic screening that you have done. Now, so the aim is to look for 4 chambers and 6 connections. They say that, okay, the basic screening is about the planes and the echocardiography is about looking at the structures. So you're going to look for 4 chambers and 6 connections, 2 veno-atrial connections, 2 atrioventricular connections, and 2 ventriculo-arterial connections. Now, the extended basic screening primarily has 5 steps. So situs, 4-chamber view, the LVOT, RVOT, that is the outflow tracts, and then you have the 3-vessel and the 3-vessel tracheal view. Fetal echo, when we talk about, then you have this basic cardiac screening plus the use of color. Then you have additional views like the longitudinal views, the arches, and the bicable view. Ductus venosus is something that you look for. You look for the, you're already, along with the bical view, you will look for the systemic veins. Spectral Doppler, the use of spectral Doppler to across the AV valves, the semilunar valves, and the pulmonary veins. M mode when you know, for heart rate and when suspected rhythm abnormalities. But let me tell you that though some guidelines say that the use of color is a part of the fetal echocardiography, use of color should be a part of your basic cardiac screening, and you will do wonders with your diagnosis. Don't restrict it to fetal echo. Make it a part of your routine cardiac screening. So every time you look at the 4-chamber view, also see that in color. When you look at the LVOT, see that with color. Especially the 3-vessel tracheal view, the color flow is such an important thing, because if you find that there is a retrograde flow, that itself tells you that there is something wrong, which is higher up. So use of color should be there, and then you can use optional things like cardiac biometry, tissue Doppler, 3D, 4D, fetal stick. I'm not getting into fetal echocardiography in detail at all, but the technique is important. Now, there are 2 ways that we look at the heart. You either take a craniocaudal, you know, that is must. You have to take a craniocaudal sweep where so you start from the abdomen and just keep going in a transverse section, from the lower end to the cranial end. So you have a cordocranial sweep, and you will find the 5-chamber view. Then you will see the 3-vessel view and tracheal view. But you also need to have a rotational technique where you are able to see the outflow tracks better. So I have the LVOT technique, and I need to see the RVOT. So I need to rotate and try to get the pulmonary artery and its branches, or the ball and sausage appearance that we get OT. So with a combination of both the sweep as well as the rotation, you need to take the abdominal section with the stomach documented. You have the 4-chamber view, the LVOT, the RVOT, the 3-vessel view, and the 3-vessel tracheal view. And you do this along with color. And then, of course, you can have as I said, if you want to do the fetal echo, then you go ahead and take the longitudinal views of the aortic arch, the ductal arch, and the bicaval view. So when you start off, your primary evaluation tells you, because you're going cordocranially, first of all, it tells you about the situs. Then you need to look at the position, the axis, the size, and the squeeze. That's a primary thing, because a lot of this actually gives you some kind of a clue that there is a possibility of something being wrong with the heart. But then once you have done this primary stuff, you have to now get into you need to get into the 4-chamber view, which itself has its own guidelines, where you are supposed to, okay, the position, the axis, the situs size comes here, but then you have symmetry, a very, very important thing. We are very fortunate that God has made the fetal heart at the mid trimester such that you have the LV, which are nearly equal in size, and the LARA nearly equal in size. So any kind of an asymmetry gives you a clue. So we need to look the morphological chambers, whether just everything side is not the right side morphological chamber. So there are clues towards finding whether this chamber is morphologically the left ventricle or not, or morphologically the right ventricle or not. The 2 atrial, IVS, IAS, that's I can speak for 2 hours on just basic normal this thing, but I'm just going to give you a few examples. Area behind the heart. Now, if you start looking at the area behind the heart, you're normally supposed to see the pulmonary veins which are kissing the aorta, and there is a descending aorta which is seen in cross section. If at all you see another tiny vessel, normally that could any tiny cystic structure, that could be the esophagus, or it could be an azygos, but then they are much smaller than the aorta. But at times, if you see 2 vessels behind the heart, then you are dealing with an azygos continuation. Or if you find that the area behind the heart is increased and you are seeing a confluent vein behind, then you are dealing with anomalous pulmonary venous drainage. So the starting point is coming from your basic cardiac screening. Then you would go forward and try to confirm, take use of other planes, and then do that. Chamber asymmetry. Simple thing. If you see that the chambers there is disproportion in the chamber size, it is an early indicator of abnormal fetal cardiac development and flow, and it is straight away a sign, indirect sign of a cardiac anomaly. So if any abnormal chamber size suggests there is a problem either in its inflow or outflow, and then okay, I'm seeing the LV which is appearing small. I know there could be a problem either with the mitral, or it could be a problem with the aortic or the aortic arch, and hence I know that I have to go forward and look at the LVOT and the aortic arch properly. And certain early changes are difficult to discriminate from normal at times. Like, okay, I have a very, very, this doesn't require rocket science. I know there is a significant asymmetry. The LV is absolutely small, and it is, a very small hypokinetic LV. There is only one side you are getting those. You are seeing only perfusion across the tricuspid valve, there is no perfusion across the mitral valve. I know I am dealing with a hypoplastic left heart syndrome. Then with a similar this thing, I will show you that here, of course, this tells me there is a disproportion in the ventricular size. The LV appears small than the RV, but LV is appearing narrow there. And when I go into the three vessel tracheal view, I find that the aorta and the aortic arch is narrow. Then you go forward and then you try to find out and whether there is a shelf. And then so the starting point was the asymmetry, which eventually led to a diagnosis of coarctation of aorta. Here, then you need to look at the septum. Now, that is where I say the use of color comes very, very handy. On grayscale, the small VSDs you may not pick up at all. But when you put in color, you find that yes, there is a flow across the septum, and you can always confirm by going into the lateral view and confirm, because that the flow would be perpendicular and you are going to get a better visualization there. Look at the crux. We always say about the crux, so that there and the valves are important. It's not just looking at the opening and closing of the valves. We know that each atrium has to open into its respective ventricle. Now here I am seeing two valves, but both opening into a single ventricle. So it is, yes, there are two valves which are opening, closing. I am seeing two inflows, but I also need to see whether the inflows are into their respective ventricles. Here, the both into the same ventricle. So there is a bulboventricular foramina. There is the Malpost vessel. So a diagnosis of double inlet left ventricle is made there. Looking at the outflow tracks, look at concordance, size, valve excursion, crossover, direction of the flow. All these small things are very, very important. In the LVOT, we need to look at the septo-aortic continuity, the aortomitral continuity. RVOT, we need to confirm the branching of that will tell me about the concordance. And the septo-aortic continuity is one of the most important things that I would say. So the septo-aortic continuity and the crossover of the vessels. Both these things are the most important things that you look in the outflow tracks, which eventually give you a good clue. And then you can categorize outflow track abnormalities as abnormal septo-aortic continuity with a malaline VSD, or abnormal crossover where you have parallel vessels, or abnormal or obstructed semilunar valves, which we talk about the aortic or the pulmonary stenosis. There you can see that we have a four-chamber view which looks normal, but then there is a malaline VSD with overriding of aorta, the I sign. I can see the pulmonary artery which is arising from the RV but is narrow, suggesting infundibular stenosis, and there is antegrade flow in that. With all these findings put together, I know that I'm dealing with a classical tetralogy of Fallows. And if I find this finding, for me, the pulmonary artery becomes very, very important. And I can use an algorithmic approach, because every time I see a malaligned overriding of aorta, it is not necessarily a classic TOF. There could be other reasons for that. And I would look at the pulmonary artery, its origin, size, and flow, and use an algorithmic approach to come to a diagnosis there. And if I have parallel outflow tracks, I know I'm dealing with either a DTGA or a CCTGA or a DORV. And here you can see the four-chamber view looks normal. There are parallel outflow tracks. Then I go forward and look at each outflow track, and I see that the vessel which is arising from the LV, the one which is bifurcating and which is the pulmonary artery, and the one which is arising from the RV is the one which is the aorta, and a diagnosis of a DTGA is made. And flow across the valves, you can find here, like you can see that there is a little post-valvular dilatation. There is, and of course, not very, very high, but a velocity of 175 centimeters per second is telling me that at this moment, I'm dealing with a mild pulmonary stenosis. Now, this could eventually evolve into a more severe pulmonary stenosis there. Three-vessel tracheal view, one of the most important view that is required in cardiac evaluation. Here you can get you need to look for abnormalities in number, alignment, size, direction of flow, interrupted vessels, and abnormal relationship with trachea, all these things that you need to look for. You can see 4 vessels in LSVC, or maybe the 4th vessel could be a vertical vein of a supracardiac TAPVC. And if you see a single great artery with the SVC there, this single great artery, if it is of normal size, then most likely the 2nd vessel is present, but it is behind this. So if you go oblique, you will find the parallel outflow tracts. And if you find that this vessel is dilated, then this could be either a common arterial trunk, or there is a significant atresia of the other vessel, and as a compensation, this vessel has dilated there. And you can have abnormalities in the size of the vessels, which you can pick up on the 3-vessel tracheal view, and direction of flow. That is what I was talking about, because the direction of flow in and a retrograde flow in the 3VT view. Suppose if there is a retrograde flow in the aortic arch in the 3VT view, then it is telling me about left-sided obstruction, and retrograde flow in the ductus arteriosus is telling me about the right-sided obstruction. These are ductal dependent lesions. Even if you make this diagnosis towards the end of pregnancy, it's still beneficial for the patient, because these babies are the ones who need to deliver in a tertiary center. And then you also look for all these kind of abnormalities of relationship with trachea, like the right aortic arch and the double aortic arch. All those things you need to look for. So what are the steps involved is, first and foremost, start learning to recognize normal as normal. Once you have done that, recognize abnormal as abnormal, and then achieve the final diagnosis. Whenever in doubt, seek a second opinion. And if you have taken a second opinion, try to achieve a follow-up. Once you achieve a follow-up, if your findings were right, your confidence will increase. If your findings were wrong, or there is something else that has been added, you can always learn from that and put that extra effort in the next thing. So if you have optimized the image well, you are patient, and you have followed protocols, which is only then that you can say confidently that, yes, I look at the heart, I evaluate the heart. It's challenging, but it is achievable. Spend adequate time initially, follow guidelines. Scanning the 4-chamber view and the 3-vessel view, or the 3-vessel tracheal view, has a sensitivity of 88% with a specificity of 99%, if not specifically to make a diagnosis, but definitely to suspect that there is a problem with the heart. Thank you very much.
Thank you very much, Dr. Bimal Sani, for that absolutely fantastic new look, if I may add that, into how we want to practice the evaluation of diagnosis of congenital heart disease in everyday use. And we do understand that, yes, there is so much that needs to be done. We understand that a lot is being done. We also understand that a lot of us are now managing to follow protocols, making sure that we create our own way around this, and ensuring that we're making much more of a diagnosis than the tragic 30 to 50% that we were doing just 10 years ago. And we will have more on this as we actually go along the evening, and we will build on this subject. But before our panel discussion, there is one more topic that I want everyone to get inspired with, and that is the one that Dr. B.S. Ramamurthy is going to be speaking on. He needs no introduction. He is the best known figure that we have in the world of imaging today, and I am truly looking forward to his presentation. And so over to you, Dr. Ramamurthy, for your presentation, for making us aware of what we should be doing about congenital heart disease.
Good evening, everybody. And at the outset, I must thank my dear friend, Dr. Ashok and Dr. Bimal for this kind invitation. And Dr. Bimal has already laid the background for us. I just hope I can carry on from there and at least live up to at least a little of what Ashok has said of me. With that brief prelude, let me get into the lecture itself. And what I'm going to do is to look at the status of screening. Just a second, yeah. Yeah, the status of screening for congenital heart disease. So the way I'm going to take this forward is, number one, why do we need to screen a condition which is there, prevalent in the population, is the condition which needs to be screened, not those rare disorders. So lay your reasons out for justifying screening. Then what is screening? One slide of what is screening all about. And then what is the hardware, the wherewithal that we have to effect screening? And then what are the present status of screening and detection rates? After all, when you screen for a particular condition, you will have to talk on the detection rate or the sensitivity, right? Okay, a participant has enabled closed captioning. Who can see the screen transcript? Okay, I'm going to close this. I'm going to take off the floater, hide the floating meeting. Yeah, now I'm set. Now I'm set. So first is there a case for screening at all in congenital heart disease? So first of all, we need to understand that the incidence of CHD is 8 per 1,000. And of this 8, at least 3.5 or 3.5 per 1,000 live births are major CHD, and major CHD are those which require intervention within 1 year. We need to remember that CHDs are the commonest among the congenital anomalies. Most CHDs are from the low risk group, and this is very, very important to justify that there is a need for screening. 50% of deaths due to congenital anomalies are contributed to by congenital heart disease. 2 lakh children with CHD are born in India annually. Approximately 20% of them need surgery. That means if you calculate, you will see that at least there are 40,000 surgeries which are needed in the country for children born with CHD. And in 2016 and 17, of this projected 40,000, we had only 9,700 surgeries done on these little kids, right? So this tells us that, yes, CHD is there, and we need to have a screening protocol in place simply because it is a high prevalence disorder. Right. Okay, so clearly the incidence is high and the burden is huge. Now, are there preventive measures? Not really. Folic acid, maybe. Supplementation may prevent CHD. And secondary prevention is by TOP, opted by couples for major CHD, right? The incidence of CHD is greatest in the low risk group. Very important. And that is why we need to look at the entire population when you do a cardiac screening. In fact, the word screening engenders the fact that you're throwing the option out or the screening test out to everybody across the population, irrespective of gestational age, maternal age, low risk pregnancy, high risk pregnancy, nothing. It's just a universal screening that we're talking about. We need to proceed with invasive testing and further genetic workup in certain situations. We need to assess these little hearts by follow-up examination to assess evolution. And most importantly, we need to run the couple through a pediatric cardiologist, because with that kind of information, they would know what are the options open, the option of TOP, the option of immediate postnatal cardiology care prior to surgical repair, planned surgical repair, what is the kind of counseling facts that we need, the acceptance, preparedness, finances, other arrangements, so on and so forth. Post-op mortality, morbidity, short-term and long-term, and it's the best way to do this is to have a sitting across the table with the pediatric cardiologist. Post-op outcome in prenatally diagnosed cases is better, and we have evidence to say that if a CHD has been diagnosed in utero, this baby would do much better than a similar CHD in another lady who has not been diagnosed, but for the first time diagnosed only postnatally. Right? So prenatal diagnosis makes all the difference. And this is an article which tells us out of 26 cases detected, only 2 cases came from the so-called high-risk group. 24 cases came from the low-risk group. And that is why it's universal, inclusive of everybody, all pregnant ladies across the population. Here is evidence to say that the newborns with a postnatal diagnosis were more likely to die of cardiovascular compromise prior to planned cardiac surgery than were those with a prenatal diagnosis. So the outlook for prenatal of the management of CHD and the success rate is influenced remarkably by antenatal or prenatal diagnosis, right? Now, what are the attributes of a screening test? First of all, it's applied universally across to the entire population. The prevalence of the disease which is being screened for should be high enough to justify screening, and we have already done that. We know the great burden or the great incidence that we spoke about in the first 2 slides. The screening test should be safe, easily applicable, universally acceptable, universally available, and reasonably affordable. It should detect a high proportion of positive cases, and there should be a system in place for management of detected cases. If we do not have a system in place for management, then there's no point in detecting these cases. So those are the prerequisites of an ideal screening test. Now, I just want to digress a little bit and compare CHD screening with another entity that we screen for, and that is chromosomal abnormalities. So we all do down screening and screening for aneuploidies from ages, isn't it? Now let's just compare and contrast between the two. If you look at the incidence, CHD is definitely higher incidence, and aneuploidy is about 4 times less in incidence. Or the other way, CHD is 4 times more commoner than aneuploidy, point number 1. CHD screening depends upon direct examination of the heart as a single stage, whereas aneuploidy screening involves non-invasive testing in terms of risk assessment. And of course, once this gets us to the high risk range, we need to do an invasive testing to prove that indeed this fetus is aneuploid. And therefore, this is 2-stage, and therefore first stage is an indirect kind of an approach. Whereas here it is single stage and you're directly seeing the heart. CHD, there is always a therapeutic option, and that is where the pediatric cardiologist is going to step in. Whereas in aneuploidy, the only option is TOP. If a lady says, even if it's an aneuploid fetus, even if it's a Down syndrome fetus, I'm going to look after my child, then that couple will not justify screening, isn't it? It should make a difference in management, and the only option is TOP. CHD is relatively, looking at the heart is relatively inexpensive, but aneuploidy screening is expensive, definitely expensive compared to CHD. There is no procedural loss in CHD, whereas under aneuploidy, we need to understand that there is an invasive testing related loss that is always there. The false positivity is less here, and here, of course, the false positivity is high, and both of them, of course, need expertise. So you will understand that CHD screening is definitely more on cards or more relevant when you compare to an employee. And how do we do the screening? And taken the ISWAC practice guidelines for sonographic screening of the heart, which tells us that we need to have all these 5 planes which are studied. And of course, you need to know that equipment optimization and expertise are extremely, extremely important. I would also add rotational views once the operator is comfortable with these 5 essentially parallel slices. So therefore, technique-wise, it's no big deal. You just sweep from caudocranial, as Dr. Bimal said. If you add your rotational skills, then your LVOT and RVOT begin to sparkle, right? And you need to use B mode or grayscale and M mode, and color Doppler is definitely a must. And this slide is just to show you the standard planes, which Bimal has already taken us through. But remember, this cluttered slide with all these small little font size writing over here is the checklist. No view of the heart, whether you've seen it real time or a still, whether it's a single plain clip or a sweep that you're going to take, none of them are complete unless you run a checklist. For example, this is a 4-chamber view. I need to run the checklist. This is the LVOT. I need to run the checklist. RVOT checklist. 3-vessel trachea view checklist. Unless we consciously do this checklist in our brains, you will not be doing justice. And that is extremely, extremely important. And this is just to remind us again and again that color is a part of the basic screening that we are actually throwing open to the population. And color definitely not only helps in the regular patient, but it's of more value in the obese patient, high BMI patients. And of course, there is no first trimester cardiac screening without color. So color is extremely, extremely important. This is again to say that you may not have the primary operator who is in the community who is offering screening pick up the final diagnosis. Oftentimes, the primary operator finds something wrong, and with that initial finding, refers over to operator 2 and 3, and operator 2 or operator 3 gives you the final diagnosis, and then you run the couple through the pediatric cardiologist and maybe genetic workup if there is a need to it. So therefore, final diagnosis may not always occur at the primary screening level, but it suffices to say that just by suspecting something, the primary operator has really, really contributed to screening. His or her contribution cannot be underrated. Because of his contribution or her contribution, the final diagnosis was obtained, albeit through operators 2 and 3. Right? So here the basic operator said that the crux looks abnormal, I can't say anything more. And operator 2, who did a fetal echo, talked of a DORV, TOF type, as you can see here, right? This is another example, aorta dilated in the 3-vessel view, nothing more beyond that. But another operator looks at the aortic valve thick, aortic flaring, yes, do your Dopplers, you have elysing, which is happening over there, and you are diagnosing subcritical aortic stenosis, do your spectrals and do the entire workup in terms of a detailed echo. Again, here, this slide is detection rate of severe CHD, for example, HLHS, univentricular hearts and heterotaxy is much more than subtle. I've only kept these 2 clips alive, and that's a very easy diagnosis of a hyperplastic left heart syndrome. Whereas here, it's a more subtler. The 4-chamber view looks normal, except that there's a twig sign here. The distance behind the heart is more, and this is a subtler pickup. This is a grosser pickup, and therefore, in the population, isolated TAPVCs tend to get missed, whereas HLHs tend to get picked up easy, right? So simple versus complex CHD. CHD detection in the 4-chamber view is much better, whereas CHD detection in the outflow tracts is a notch less, perhaps. and non-evolving versus evolving lesions makes the difference. Now, what are the evolving lesions? Coarctation of aorta, aortic stenosis, pulmonary stenosis, cardiomyopathies. These may actually manifest post the mid-trimester window. So therefore, even if the mid-trimester window or the echo study is normal, extended basic study is normal, you might still have problems which are popping up after the mid-trimester anomaly scan window, right? Some of the postnatal CHD is physiological in the fetus. For example, a secondum ASD. A secondum ASD is not something that you can see in the fetus because secondum ASD can be detected only after the flap closes against the interatrial septum, whereas in the fetus, the foramen ovale is open and the flap is moving around. Therefore, secondum ASD cannot be detected in utero, and ductus arteriosus is physiologically patent in the fetus as well. Some subtle lesions, such as very small VSDs and bicuspid aortic valve, will definitely escape our attention. Now, how do we perform as far as the mid-trimester scan goes? Even in developed countries, you have a detection rate of 30 to 50. The Belgian Eurocat data between 1997 and 2012 talks of 29.3% detection rate. The Dutch data talks of 60%, and meta-analysis in 2017, where 7 studies were included, talks of 45. So even if you were to take the meta-analysis detection, pooled detection rate, you would be landing up with a figure of about 45, which is not very much at all. It suffices to say that the detection rate of CHD is low, and even in the same country, different regions of that country can have different detection rates. And that is what is seen in Baker et al.'s article. We must aim for a detection rate of at least 80%. And why this happens, we will come to it a little later. But remember, the low detection rates, what are the reasons? Lack of infrastructure. We need equipment and expertise penetrating across. We are sitting in the metropolitan cities, but it should penetrate across to the second-tier cities, to the district headquarters, and ultimately to the taluk representative places. Only then you will have the entire program in place. So it should penetrate healthcare levels. And healthcare in our country, unfortunately, is not state-sponsored. It's largely not insurance covered. And there are more pressing issues which face our governance today. For example, reducing maternal mortality rate is a much, much more pressing need compared to detection of fetal CHD. Inadequate protocols, failure to run through the checklist, suboptimal imaging due to obesity or due to erroneous presets or erroneous equipment optimization. Milder forms of CHD are easily missed, and late onset CHD is missed in the mid-trimester anomaly scan period. So it's important to have systematic training and quality control and spread of the entire process of screening out from the centralized urban huge metropolises down to the taluk level. That's extremely important. The detection rates of CHD are increasing, and why is it happening? Increased uptake of MTAS. The mid-trimester anomaly scan is indeed an accepted norm of practice today of standard obstetric care. Increase in trained expertise, and thanks to the efforts of societies like SFM and the unrelenting, thrust on education and dispersal of information, there is increase in trained expertise, availability of resources, presence of local secondary and tertiary centers. Remember, I may be sitting in Bangalore, Ashok may be sitting in Delhi, but even our second-tier cities, Bimal is in Aurangabad, somebody else is in Nasik, somebody is in Gulbarga, and even at more peripheral centers, you have centers of excellence, one or two people who take it up as a passion, and that is enough. That is really enough to set the mood going as far as the penetrance of the screening program in our country. Also, ability to share videos via internet for cross-consultation, and that's a big boon. And we know there's so much of cross-consultation on WhatsApp today. It's unbelievable the number of groups that I can see, right? Improvement in equipment performance is definitely important. And today we see much more spectacular images of the heart than what we did about 20 years ago, 15 years ago, so on and so forth. I will not take you through this, as this is the indications of when you will leave the extended basic and look at detailed, dedicated fetal echocardiography, right? A word on first trimester screening. We need to understand that mid-trimester screening is the foundation, or is actually the solid basis on which screening is built. But you also have a second window in the 11 to 14 week scan where you can screen for CHD, and there you have the option of TVS, and there of course you have the protocol is different. You have the upper abdomen 4-chamber view in grayscale and color Doppler, and 3-vessel view in color. So if I see two of these parallel streams going across, I'm quite relieved, right? And remember, color is indispensable in first trimester screening, and this is the 3-vessel trachea view. And if I see this beautiful V happening there, I'm quite assured that yes, with the two parallel outflow tracts and with the two converging and two parallel inflow tracts out over here, and the outflow tracts which are converging, the ductal and the aortic arches, I'm sure that this heart looks pretty normal. And this, of course, is a PAVIS, and I will not take you through the details. You can diagnose, you can make your diagnosis in the first trimester, at least in the grosser kind of situations, right? Okay, in the first trimester, again, the situation is a little different, because in the screening protocol for aneuploidies, you have 3 markers, which are nuchal translucency, tricuspid regurgitation, and A-wave reversals in the ductus venosus, which are all not only markers of aneuploidy, but also markers of cardiac disease. And therefore, if you were to look at a subset of population, here is a thick nuchal fold, and ultimately this was a Epstein's anomaly. This was an Epstein's anomaly plus a functional atresia that you have picked up in the first trimester. You can see the tricuspid regurg there, and you can see the reverse flow in the pulmonary artery as early as 12 weeks or 13 weeks, right? So if you have a clue with your other markers, then your pickup rate is more. You're going to look at the heart in the first trimester itself. You're even going to do a transvaginal scan to look at the heart. And if you do not have the wherewithal, you will definitely send these cases out for an opinion in the same sitting, in the same time window. And here is an article by Asma Khalil et al. Shows you that for a given delta nuchal translucency, if TR and DV are both abnormal, then the risk of cardiac defects zooms up like this. You are really looking at a high risk situation. Whereas if both are normal, then you're looking at a lower detection rate of congenital heart disease, risk of congenital heart disease. If the TR is present and ductus venosus is normal, the curve is B, and if the ductus venosus is abnormal, but TR is normal, then you have C. And therefore, we need to understand that if the NT is high, tricuspid or ductus venosus waveforms are abnormal, or there are combinations thereof, please look at the first trimester heart with greater detail. And with that, we move on to the 2021 meta-analysis by Aris's group. And here is the low-risk population, 11 to 13 weeks, 6 days, and the pooled detection rate is 0.55. 55% detection rate, and quite a large number of studies are included. You see the forest plot here. That is the pooled rate here. That is the pooled rate, which is 0.55 or 50%. But however, I draw your attention to the I-squared here. This is an index of heterogeneity. I would love I-squared to be below 50%, but here it's close to 100%, which means that all these studies were heterogeneous. They did not follow the same protocols, and therefore the robustness or the fact that 55% could be detected is not going to be it's not going to be based on a set of homogeneous data, but it's a very heterogeneous group. That's for low risk. And for, if you look at the high risk data, it goes up to 68%. And again, look at the I-squared, it's large, it's close to 85%. And therefore, although the heterogeneity is there, the detection rates in the first trimester are pretty good. And therefore, first of all, get good in your mid-trimester work, and then all of us have to make this quantum shift, move into the first trimester and look at the heart very carefully in every first trimester scan that we do. Now, the challenges in our country is that our country is absolutely heterogeneous. You have developed areas versus underdeveloped areas. You cannot compare South Karnataka, for example, to a tribal area in Chhattisgarh. You can't, right? You have urban versus rural. You have state versus district versus taluk headquarters. You have teaching institutions, non-teaching institutions. You have corporate hospitals, non-corporate hospitals, diagnostic imaging centers, fetal medicine centers. The challenge is to disseminate the correct protocol and build up the bank of expertise. And this is where we have the role of national and local professional bodies, online, on-site teaching resources, courses, lectures, and demonstrations, right? And then, of course, let me hide this. I'm not able to read the title here. Okay. What do we expect of the referring obstetrician? After all, the case comes to us through an obstetric healthcare provider, right? First of all, the obstetrician should avail the fetal medicine imaging services from centers, which include extended basic echo in the mid-trimester anomaly scan. They should ensure that the patient goes to a center where heart is a part of MTAS. To encourage the study of fetal heart in all MTAS and include the findings in the report and images. Please make sure that the heart is committed upon in the report. That is what an obstetrician can do to promote screening, and of course have a glance at the image to see if there's an image or two of the heart which is included, and that is by studying the hard copies which the patient carries, right? And you can have a lecture on how to document, because today we have matchbox label sized images, you know, an array of 50 images in one sheet, and each image is less than the size of a coin. I don't know what it is at all. I mean, even if I use a magnifying glass, I can't see. That's not documentation. In proper documentation, a couple of these images tells the obstetrician that yes, the operator has seen the heart. That's very, very important, and the obstetrician has a great role to enforce and to say that yes, we must encourage seeing the heart in the mid-trimester anomaly scan to begin with. So to wrap up, prevalence of CHD necessitates screening. It definitely screening is on cards and very relevant to CHD. Screening for CHD classically in the mid-trimester, 18 to 22 weeks. Protocol of sections and checklists, necessity of equipment and expertise, skill development and deployment. First abnormal finding to final diagnosis may take 1, 2, or 3 operators. Increased penetration of equipment and skill is what we are seeing in our country today. Obstetricians must encourage extended basic cardiac examination, and a huge advantage accrues if the CHD is prenatally diagnosed. Thank you very, very much for a very patient listening. Thank you. Thank you.
Thank you very much. Thank you very much, Dr. Ramamurthy. We've had one of the most spectacular talks we've ever heard on the subject, and I know it will go a long way to inspire all of us, and of course, ensure that we get this message across to many more people than just the ones we've tuned in today, because we hope to share this on other social media as well. We've had very spectacular talks, one from Dr. Bimal Sani and one from Dr. Ramamurthy, and we hope to build up on these in the panel discussion that's going to follow. But before we go onto our panel discussions, I'd like to take a few minutes off so that we can present messages from our trade partner for tonight. So over to the back office for presenting the trade video. Welcome back after that break, and after those two very spectacular talks that have laid the foundation of what we do with these babies and how best to handle this, we move on to the next part of our program, which is a panel discussion. And the theme here is a prognostication and surveillance of congenital heart defects. We have a fabulous team with us. Excuse me, the session is moderated by Dr. Vandana Bansal, who is part of our executive in the Mumbai team and associated with Surya Hospital in Mumbai. She's also associated with Vadya Hospital, and we know she has one of the most marvelous collection of cases that we ever see, and we hope to learn from all of these today. Supporting her on the panel is somebody I always refer to as the people's geneticist, Dr. Ratnapuri, a former president of the Society of Fetal Medicine, chief of genetics and genomics at Gangaram Hospital in New Delhi. We have Dr. UP Singh, who joins us from Chandigarh, where he is not only one of the most favorite pediatric cardiologists for everybody, including the unborn child, but also somebody who supports us constantly for reviewing the entire cardiac content for the Journal of Fetal Medicine, and we always remain grateful to him for this. We have Dr. Balakanesh Karmagraj, who is from Kerala. He is associated with Amrita and has a large practice of his own. He also has the distinction of having 3 images on the cover of Ultrasound in Obstetrics and Gynecology, the White Journal, the only person in history to have had that distinction. And it's so wonderful to have him here. We also know he's part of a fabulous program where the government of Kerala has taken pediatric surgery and pediatric cardiac surgery to the people, where they've made it free of cost to anybody in that state. And it's really an example to emulate. So we look forward to his inputs. We have Dr. Chinmay Rath, who needs no introduction, the author of what I can't call an absolutely fabulous book, because I am the co-author with her on that, but truly a book that everyone would like to have. But in addition to that, she has been associated with Society of Fetal Medicine since its inception and is currently chief of our unit of the SFM regional chapter of Telangana. We also have Dr. Alok Varshne, who is part of our Delhi SFM team. You have seen his spectacular pictures off and on, the most fabulous images that you will find. And his cardiac images in Delhi are really legendary now, something he's achieved at a very young age. Welcome to all of you, and I look forward to this panel discussion. We have about 45 minutes, but let's take it at a slow pace so that we can benefit irrespective of whatever is our level of expertise. So over to Dr. Vandana Bansal to take this forward.
A very good afternoon, sir, and thank you for this panel. This is going to be on all clinical cases that we are going to see as to how we are going to manage after a diagnosis which was made by Dr. Bimal Sani and by Ramamurthy, sir. So I have an excellent panel group with us, which you have already introduced. So we will just start with the program because I have lots of cases tell me to stop wherever the time doesn't permit us. So let me start with the statistics. And we all know that congenital anomalies are about 10 per 1,000 fetuses, which are cardiac in origin. And among all of them, they are associated with high mortality. And this mortality reduces if we have a prenatal diagnosis made to improve the perinatal outcome. In addition, when we have cardiac disorders, they are usually associated with extracardiac as well as genetic abnormalities. And so when we are looking at cardiac disorders which are diagnosed, we need to look at extra cardiac defects as well as chromosomal abnormalities and genetic abnormalities. So with this background, let me go on with the panelist, and maybe we would first start with the maybe Chinmay. What kind of reasons that you get fetal echo to be done for?
Thank you, Dr. Vandana. And we've just gone through this entire introduction of what is a fetal echo. That's a very, targeted imaging of the fetal heart. And in our practice, the most common reason for doing a fetal echo is usually a suspicion of some abnormality, either due to poor visualization or some kind of a preliminary examination which has led to inadequate evaluation of the fetal heart, and which requires a fetal echo. Maternal diabetes is a very common indication for fetal echo. Maternal obesity is also a very common indication. And in many cases where the mother has pre-existing diseases, for example, epilepsy, when she's taking medication that is potentially teratogenic, that is also an indication for fetal echo. And in terms of the mother, the teratogen exposures, autoimmune disorders, and all the other things that I mentioned. And in the baby, if any abnormality is seen, apart from the heart itself, if there is any extracardiac abnormality also, there's a referral for a fetal echo, because like you just showed, there is an association with them. Increased nuchal translucency in the first trimester, single umbilical artery, what you've written here, polyhydramnios, growth abnormalities, and the presence of a monochorionic gestation that puts the fetal hearts at a different kind of pressure. So these are the common indications of doing fetal echo in the current practice.
But Chinmay, do you find that all these high-risk factors are the ones where you find cardiac abnormalities, or they just come in any patient who comes?
So that is exactly what was the essence of the previous two lectures, that while these are the valid indications for fetal echo, these are the high-risk situations where we look at the heart very commonly. It is not uncommon that when we do a routine scan, we do find a problem. And unless we do that properly, we will miss out. And that was the reason for those sad statistics which were shown in the previous thing. So most cardiac abnormalities actually occur in the so-called low-risk group.
So that is the first pointer. For everything that we talk about today, there will be some pointers. So yes, as what Dr. Ramurthy also said, almost 80 to 90% of cardiac defects occur in low-risk population, and we need to have a good screening of our cardiac disorders during every anomaly scan that we come across, and not only in the high-risk populations. So when I have a cardiac disorder, maybe Dr. UP Singh, you can take up. What are we going to look at? Is this the obstetrician who's going to counsel? Is it the fetal medicine who's going to counsel? Is it the cardiologist or the cardiac surgeon who's going to counsel? Or we need to all sit together and make a decision as to what is the prognosis of the cardiac disorder? So
I think that's very, very valid point, because issue is that all said and done, it's kind of a multi-specialty approach, which is important for management and making the patient understand. But
your voice is not clear.
And Dr. UP Singh, I think we have poor connectivity. Could you reconnect, or because we have a lot of we're unable to hear you. I mean, it's garbled speech. Sorry to interrupt. Alternatively, we could switch off your video and here have only your audio for a little while till you switch over. So we see you, but we don't hear you.
In the meantime, maybe Dr. Balaganesh can take over from here.
Yes,
As
ma'am. Whenever I usually get referrals from sonologist, radiologist, and obstetrician when they suspect a cardiac anomaly. So usually in the period of mid-trimester, between 22 to 26 weeks of gestation, first thing what I do, as B.S. Ramamurthy sir told, is I will be the operator too. I myself do the fetal echo, and for the prognostication purpose, I do the specific things which are required for counseling that particular lesion. For example, if tetralogy of Fallot is the referral, I'll look at the pulmonary valve, branch pulmonary artery sizes, and adequacy of blood flow to the pulmonary artery for prognostication. If the blood flow to the pulmonary artery is good and branch pulmonary artery sizes are very good with no flow reversal in the main pulmonary artery, the chances of correcting the tetralogy of Fallot with a single stage surgery is very high. And the second thing, which is the most important, I will not proceed without that. That is a genetic as well as extracardiac association. First thing, I will ask them to rule out aneuploidies and microdeletion syndromes and detailed extracardiac assessment. Even after a strict extracardiac assessment by a expert in fetal medicine, I am seeing a lot of fetuses delivering with the tetralogy of Fallot, with the intestinal abnormality like imperforated ANS, recurring colostomy, and all postnatally. So what I do is first assessment of heart lesion, then prognostication, whether good prognosis or bad prognosis, association with the genetic or extracardiac assessment has to be made in detail. If there is no genetic abnormalities and there is no extracardiac association, if there is only isolated cardiac defect, then I will divide them into two, whether it's a heart disease with the, which is easily correctable, and whether it is a complex heart disease. Whether if it is a complex heart disease, especially single ventricular physiology, I will tell them to terminate, or else if it is a heart disease, even if it is critical, for example, transposition of greater arteries, which can be easily corrected with a single staged heart surgery at day 3 of life, I will transport the fetus in utero to the in a center with the good pediatric cardiac facility, and the outcome will be very good, as Ramamurthy said. In utero transport is very good, very important.
So a cardiologist is extremely important, but we should not forget the obstetrician, who's the primary physician who is to counsel the parents about this, the fetal medicine specialist who's to look at the heart and the rest of the baby also for extra cardiac abnormalities. We need a geneticist because a lot of cardiac abnormalities are associated with genetic disorders, and not miss out on the neonatologist who's going to stabilize the baby first and then only give it off to the cardiac surgeon. So basically, we need to counsel the parents about the best decision for that baby, for that parent. So it could be termination, it could be a in utero transfer, it could be sending off to a place where you will have everything available under one roof, and also the need for genetic testing if required. So it's a team approach for cardiac management if we really want the best out of the baby that is born with a cardiac disorder. So let us go on with some cases. So the first few cases are on first trimester cardiac, as what Dr. Ramamurthy said, that we have increased NT as a marker and we start looking at the heart. So I think this part we will have Chinmay, Alok, and Ratnapuri madam for taking us through these cardiac disorders in the first trimester. Most of them have similar presentation and have a different genetic disorder. And so there is a reverse transition from the anomaly mid-trimester to a first trimester, and we are picking up these cardiac abnormalities. So maybe Alok sir can take this from here. We have this primigravida, a low risk patient. All cases today are going to be low risk. and the disorders associated. So there was an absent nasal bone, increased nuchal thickness, there's an omphalocele. Dr. Alok, are you there?
Yes, yes, ma'am. I'm here.
So you could
Good
look
evening,
at the
everyone.
images and can you take me through them?
Yes, so we see a fetus. It's a young fetus, and it is the NT scan, I believe. And we see in the first image, we see that the nasal bone is absent. It is marked as absent nasal bone. But what is more striking is that there is a huge nuchal translucency which is there, which is very, very wide. And the third image shows a large omphalocele protruding out of the abdominal wall. And this is all very well seen in the 3D image. And when we do a Doppler, we find that the ductus venosus is showing reversal of flow in the ductus venosus waveform.
So, sir, I haven't shown you cardiac. Do you need a cardiac assessment?
Absolutely, absolutely. If NT is more than 99 centile, then cardiac abnormality is the first abnormality which we want to look at.
So this is a 13 weeks with an atrioventricular septal defect. There was a tricuspid regurgitation, ductus reversal. So how are you going to talk to the patient with this disorder?
So there are multiple abnormalities in this fetus. So there is absent nasal bone, NT is very high, there is a omphalocele, plus a cardiac abnormality. So the fetus has a very poor prognosis, first of all. But we want to first think about whether this baby has a genetic abnormality as well. So this fetus has to be, the patients have to be counseled, the parents have to be counseled, look, the abnormality is such and such, but this can be also due to genetic reasons. So we would prefer to have a genetic evaluation in these
So
cases.
Chinmay, what test will you do? NIPT, FTS, terminate and test the abortus, or do an invasive test? Chinmay.
See, in this case, we need a definitive answer. So NIPT and FTS are out because they are just screening tests. So I need a definitive answer. Now, the prognosis is really poor in this fetus, but again, the decision to continue or discontinue depends on the parents. So if they want to continue the pregnancy, I would go for a CVS and test the microarray in that fetus and keep the DNA stored just in case something else pops up later on and we don't know what we are looking for. And if they are going to discontinue the pregnancy because of all the poor factors and the multidisciplinary team will tell them that the outcome is not good, then I can do the same microarray on the product of conception and still save the DNA, because if that comes as normal, I would like to go for more genetic tests.
So Chinmay, we are just terminating this baby. Do we still need to do a genetic test?
Yes, because you need to know what is the reason for this problem. When you terminate a pregnancy, you just solve the problem as it is as of now. But once you terminate a pregnancy, you're looking forward to a future pregnancy when they would have an expectation of a better outcome, and everything there will depend on the cause of problems in this pregnancy. So even if they are terminating, the genetic workup is a must.
So this came out as trisomy 21, pure trisomy 21. So what is the recurrence in next pregnancy?
Since this is a pure trisomy 21, I would expect the recurrence to be about 1% more than the background risk, because the cause of this is a non-disjunction. It's a meiotic event, and it's like every time there is an independent risk that the fetus has. Since the mother has one of these conditions, her risk will be 1% more than the background risk.
Dr. Ratnapuri, madam, she said that if we are terminating, we could send the sample of the abortus. So is it good enough, or should we do a CVS in all our cases?
So it depends upon where you're terminating the pregnancy. If the facilities are there and you're very sure that in the abortus, that is in the fetus only, you can take a direct sample even after delivery, that the sample will be taken. It's not something that's happening in the middle of the night. The resident doesn't know, the nursing staff doesn't know what to do, because then that's a lost opportunity. So where there is even the slightest doubt that a sample will not be collected post termination, then you should take an antenatal sample, because you need to do a karyotype, and a fish is not good enough. So in this situation, I would just, if it's a direct fetal sample, I would, want to culture it. and do a karyotype or a microarray, because you really don't know. But here you strongly suspect, even though there is an omphalocele, because there's an absent nasal bone, you don't suspect a microdeletion. Things are going in favor of a abnormality of number, which can be picked up by a cheaper test, which is the karyotype. Now, whether it's 13 or 18 or 21 will all be picked up by this.
So the learning point is that genetic testing is extremely important, even if the fetus is obviously an aneuploidy. This looked like trisomy 21, but the type of trisomy is important. Dr. Ratnapuri, can you just describe what is the recurrence of all of these?
I will. So the first image is trisomy. It's a free trisomy 21. These are all trisomy 21s. You cannot have Down syndrome without trisomy 21. But this is a free trisomy 21 present in about 95% of cases where the 3 chromosome 21 is free. This is a non-disjunction event at the time of meiosis. And here the recurrence risk, as Dr. Chinmay has said, is 1% more than the baseline risk. On an average, it's about 1%. Now here we have another what is referred to as a translocation Down syndrome. That means that the 3rd chromosome 21 is translocated onto another chromosome. The most common are these Robertsonian chromosomes, where there is no P arm, or there's a very small P arm, and there's a predominant Q arm. So this 21, which is also a Robertsonian chromosome, goes and piggybacks along with one of them. So here you see that they are 46. This should be 46, not 45. Because they are 46. This is a carrier. So 45, this lady is a carrier. So that's how you differentiate whether this is an affected or a carrier. Whilst a third situation where you have the free chromosome 21 that is piggybacked on to the 21 itself. Now this may be inherited from either parent, or it can be a de novo event, something that's happened by chance. If any of these translocations are de novo events, the recurrence risk remains again about 1%. However, if the 21-21 is inherited from if it is inherited from a carrier parent, there is 100% chance of always having a baby with Down syndrome in every pregnancy. Because it's easy to understand, if this is a carrier, this will always come together and one has to come from the other partner. And for the other translocations, it varies between 5 to 15%.
Thank you, ma'am. So we go on to our next case. Again, a primary gravida, increased nuchal translucency. So again, Alok sir, you can take me forward from here. Here we don't have a tricuspid regurgitation, but there is some amount of pleural effusion.
Yes, so there is, first of all, the nuchal translucency is very, very big. It's almost 13.5 millimeters in size. And we see that there's a lot of hydrops. There is pleural effusion on both sides. And the ductus venosus seems to be absent. We do not see the proper ductus venosus here. So these are the imaging findings which we can see here in this case.
So Chinmay, what are we thinking of?
Well, with this nuchal translucency and the abnormality of a ductus venosus agenesis, I would still think of aneuploidy, and I would like to test for, do a CVS and test for aneuploidy.
Yeah, so here in addition, we wanted to see the heart, and there was a single outflow tract which was coming out along with the ductal agenesis. So Ratnapuri madam, you help us with this case. We are thinking of aneuploidies. We could think of Noonan also. What is different in Noonan from an aneuploidy here, madam?
Ma'am, unmute yourself, please.
Sorry. Can be an aneuploidy. It can be even a chromosomal deletion duplication syndrome. So we know amongst the common aneuploidies 13, 18, 21 that can be picked up by a FISH or a chromosomal or a QF PCR. And if that is normal, then you go ahead and do a microarray. In this case, I don't think that there would be a scope for a karyotype because you have a single outlet. So I would do first a short test, a QF or a FISH, depending upon what the lab does well, and then take forward a microarray if that is normal. If that gives us the answer, then you go ahead and do the karyotype. If we've excluded chromosomal disorders, only then we would take forward a Rasopathy panel for Noonan syndrome.
So, madam, we were thinking it to be Noonan, but we first sent for a FISH, as you said, and it came out as monosomy X. So it was a Turner syndrome which came up. So what is the recurrence and what is the prognosis? Can we continue this pregnancy?
Well, we have to tell them what Turner syndrome is. So first is, Turner syndrome is not associated with intellectual disability. And it is associated with short stature, it is associated with hypogonadotropic hypogonadism, which can be managed. But yes, they would have problems in conceiving. And the second thing that needs to be looked into, can the cardiac lesion, what is the outcome of the cardiac lesion? Can it be operated, etc.? So I would want to send the person to my pediatric cardiologist to take it forward, as well as counsel them. But from experience, there are hardly any people who opt to continue a pregnancy, especially if it's identified so early. But it's a matter of choice.
And with all these anomalies, if it was pure Turner's, it's different.
Yeah.
But there are so many abnormalities there.
Yeah.
So basically, a first trimester diagnosis takes us more towards termination rather than counseling and sending to a pediatric cardiologist. Chinmay, will you send this patient to a cardiologist or just decide at your end itself?
No, see, the picture that you've shown is quite a severely increased NT. There is ductus venosus agenesis, and there is a cardiac anomaly there. So the prognosis is really bad. If the parents want more information, I would always want them to speak to the cardiologist, because that's a right that they have, and it helps in their understanding the situation. We all know with experience that this is a poor prognosis and probably it won't do well. So if they are not keen and they are willing to discontinue, probably we can take the decision.
So learning point from this case is that an increased NT, the higher the NT, the higher the chances of cardiac defects. And whenever it is combination with DV and TR, as what Dr. Ramurthy also said. So again, another case of an increased NT. Here you have tricuspid regurgitation also. And the outflow tracts were blue and then red. So basically, if you look at this, the pulmonary artery was red and blue and red and blue. So Chinmay, what do you think is the diagnosis of one single outflow tract which is turning blue and red?
So obviously there is regurgitation there, and there is reversal in the flow at that point. So again, a very early onset cardiac abnormality, we are thinking in terms of genetic origin. And what we cannot negate is that there is a lot of swelling around the fetus as such. So not only increased NT, there is almost an envelope of fluid around the baby. And there is probably already an ongoing heart failure happening there.
So again, the prognosis is bad. And here, pulmonary valve, which was seen. So we go on to another similar case of an increased NT. Dr. Alok, can you take me through this cranial assessment and then go on to the cardiac assessment?
Yes, so even on the sagittal plane, we can see that the head shape is little abnormal. It appears little smaller in size. And on the axial plane, we can see that there's a large ventricular cavity. It's a monoventricle. We do not see any interventricular septum in the midline. And the whole of the midbrain and thalami, they appear fused and they appear as a clump here. So this is basically a hollow prosencephaly. And in the cardiac, we do not see, there is some cardiac abnormality here. There is a significant tricuspid regurgitation which is happening. There's also mitral regurgitation is also occurring here. we see blue on the both sides of the heart. So these are the basic findings here in this case.
So Ratnapuri madam, are we looking at trisomy 13?
Yeah, because there's holoprosencephaly, and that's one of the common chromosomal associations with that, especially when you have associated other multi-system anomalies.
So that means, madam, that anybody who has a first trimester increase NT or no increase NT but a cardiac defect, we should test all these babies? Because we
Yes,
had
you
14,
should.
118, 121, one Turner with
Yeah.
this cardiac
So
anomaly.
even if there's no abnormality of number, if there's a cardiac malformation, it has a very, very high association with chromosomal disorders as a group. And in fact, it's more common with chromosomal than it is with monogenic disorders. And in the chromosomal, it's number as well as structure. So thereby, you have to do a chromosomal analysis. And that holds true even for an increased nuchal translucency.
So the points taken home is anybody with first trimester cardiac anomalies need to have a genetic testing done. So let us go on to our next major cases, the ones which are correctable cardiac anomalies, where I will need the cardiologist to work with me along with the fetal medicine and the radiologist. So I have this case of, again, one previous abortion, 23-year young, low-risk patient who was sent to us for a suspected ventricular septal defect at 19.4 weeks. This was the time when the MTP Act was only till 20 weeks and everybody would come at that 19.4 or 5. So Dr. Alok, can you take me through what can you see on the video?
So the 4-chamber view here looks almost normal. There is no abnormality. The ventricles, they are of same size. There is no chamber asymmetry here. But what we can see here is there is a small ventricular septal defect here, which is in the portion of the perimembranous region. And then we see a large size aorta coming out of the left ventricle, and it appears to be actually overriding the ventricular septal defect. But what is characteristic is the pulmonary artery, which is quite narrow in caliber compared to the aorta. But it is still showing forward flow, and it is both the vessels are showing blue color. So my first diagnosis will be a tetralogy of Fallot in this case.
Dr. UP Singh, we've described to you the trough that we are seeing. We've seen the overriding and the pulmonary stenosis. What else do you want from the fetal medicine specialist or the radiologist, or what do you see to make prognostication in such babies?
I think we've seen the patient early, and we need to know, how far this pulmonary stenosis will progress. At this point, the pulmonary artery is practically half the size of an aorta, which is a kind of an alarm, that this can progress. And even if it doesn't progress, the prognosis outlook is not very good. More than that, we have now recent data that we should look at the pulmonary artery annulus rather than the size of the pulmonary artery, which gives you a more definitive prognostic marker. So in this patient, I suspect that we might have a difficult time, that a pulmonary artery might become smaller. So that has to be actually given as a caution to the family, that repair one could be required early, or this could actually become a ductal dependent circulation.
So one is, it is an evolving disorder and we can't give a complete diagnosis and prognostication at this week of gestation. But yes, as you said, the annulus has to be measured. And I think 0.6 is the value between the pulmonary artery and the aorta that suggests that the prognosis is bad. So that's what you were referring to, sir?
Yeah.
So this patient was 19.4, but we need to look at more things. So Chinmay, how do we look at the thymus, and do we look at thymus in all cardiac anomalies?
Well,
How
yes,
does it help us?
it is a good idea to look for the thymus because, like you've pointed out, there is this 22q microdeletion syndrome where a thymic aplasia is a part of it. So the photo that you've shown us, it's a 3-vessel trachea view. And in that view, if we try and look at the area in front of that, between the like anterior chest wall and this the vessels, the anterior aspect of the vessels. That is the thymic box, which is actually lined by the internal mammary artery. So if we have the correct color settings and we try and look at those arteries there by the sides, then it defines the thymic box very well. So like you have shown here, the biometry of that area can be taken, and there are nomograms to tell us if the thymus is developing normally. So if you can demonstrate a good size thymus there, you're ruling out thymic aplasia. And we don't look at it in all cases. It's actually not practical to do it all the time, but at least when we see a cardiac anomaly and something like TOF, we must look at the thymus.
So this patient had a thymus which was small, and so was tested. So Dr. Ratnapuri madam, do we do a FISH for 22q or do we do a microarray? What is the difference in the accuracy and the cost?
Okay. So the standard, so 22q is a micro deletion. So it means it's a small deletion. It's not something that would be picked up by a karyotype, because the largest size of the 22q micro deletion is 3 MB, 3 megabase. So it's not picked up by a karyotype. You can have smaller nested deletions for 22q, and therefore I would prefer to do a microarray and not a FISH, because you want a diagnostic test with an accuracy to be able to guide the patient. So a microarray is the standard of care test.
Yeah. So this was some years back when we did a FISH, but now we are doing microarray for all of them. So Chinmay, does your counseling change now?
Yeah, once this microdeletion is detected, definitely the scenario changes. And again, we refer back to the geneticist, because again, ma'am will tell us that there will be a spectrum of presentations, including a few which may be asymptomatic, and that is where the confusion starts. So I'm going to refer back to the geneticist.
Yeah.
So madam,
Yeah.
what is a...
You know, what happens is that most of these microdeletions are de novo. They happen by chance at the time of meiosis. However, in up to about 6 to 7%, they can be inherited. So it's always good to take a history of a cardiac lesion that has been operated. It could be innocuous, they've forgotten about it. But even if it's not, there is something what we refer to as incomplete penetrance. And that is the biggest challenge to counsel for these sort of disorders. And so in some situations, you can have a parent who carries the deletion, has never had a cardiac lesion, is absolutely fine developmentally, did not have hypocalcemic seizures, did not have any developmental delay. So for 22q microdeletion, you must always test the parents. So if your deletion on the microarray is 3 MB, you can just do a FISH test. It's cheaper, okay? Because remember, a microarray costs money. And however, it's a smaller deletion, then you'll have to do a microarray or set up a real-time PCR. We often do that because it costs less. But most of the times, the FISH suffices. If one parent is a carrier, even if asymptomatic, there's a 50% chance of recurrence. But what is key in counseling these families is that if one of the parents is an asymptomatic 22q carrier, you can never know whether the fetus is going to be like a parent and asymptomatic, or have a full-blown 22q microdeletion, or just have a cardiac malformation, which is operable and then development is fine. So the phenotype can never be counseled antenatally, and that is something that we need to counsel the families about.
So as what you said, madam, we looked at the husband, and husband had the correction of TOF done in US when he was 3 years of age. So the FISH came out as positive for the father also. So the recurrence now has increased to 50% for this patient. And as you said, yes, the phenotype needs to be looked at after birth only. But here there was a conotruncal abnormalities, and so finally the patient decided to terminate this pregnancy. So a similar case now.
You know, Vandana, I think there's one thing important we need to tell the audience is that, because now what's happening is you find a malformation antenatally, and the first thing the doctors tell the families, even before they can digest it, is, oh, there's an abnormality, go and discontinue the pregnancy. So you look at that father, he did have an operable. So some of the things are operable. Yes, you don't know the full-blown thing. But even if it's a little late in pregnancy, I don't think we need to psych the families to an extent that, it's really the end of the world. So I think that because you all are identifying more and more things with better scans, better machines, better, experience and expertise.
Yeah,
So
that's
at least
what
the ones which can be operated, they should be given a chance for postnatal management.
You said it right, and this case is for that only. Again, a patient with Fallot's tetralogy, where we saw the patient at 28 weeks for a routine growth scan. And when we looked at the heart, there was an override of aorta. And when you put on color, the pulmonary artery was stenosed, probably atretic. So now at 29 plus weeks, by the time the patient came for a perinatal OPD, Chinmay, will this help the patient that we have diagnosed it prenatally, or had this come up at birth also would have been all okay? Chinmay.
Now, this is a little bit of a difficult situation because I assume that we have not yet diagnosed it. Till 28 weeks, she's been having scans and she does not know that there is a cardiac anomaly in the baby. So the first challenge is to negotiate the shock, the denial, and again, the kind of betrayal that why this was not told to us earlier. So we have to explain to the parents that sometimes it is difficult to pick up these things early and it may be missed. And now that we have picked it up, we at least know that this child will require care at the time of birth and thereafter. So it is better definitely to have diagnosed this prenatally, because if we had missed it now also, then it would have been a very, very difficult situation for an obstetrician who would be dealing with this baby like any other baby at birth. And the neonatologist would definitely see the problems, but he would not be equipped to handle them all at the same time. So prenatal diagnosis is any day better, even late, like better late than never is what I would say here. But now that we have diagnosed it, again, the entire discussion that we've had in the past in this session, that there could be chromosomal abnormalities, there could be other genetic things associated, that discussion becomes very difficult now because she's 29 weeks. And even if the parents want a lot of testing done, we have our limitations in offering those tests, and the turnaround time of those tests is almost close to delivery now. So that is a very difficult counseling to do, but we have to do it like that. So prenatal diagnosis is good. What it empowers us now is to just create our multidisciplinary team so that we can improve the neonatal outcome. So now comes the role of the pediatric cardiologist and our neonatologist.
Yes, UP Singh, sir.
Yeah, I think I'm going to first differ with the diagnosis. I'm not too sure because what single view, what you're showing is, this is TGA. You see the pulmonary artery, which is small, which is coming from the left ventricle. And you have an aorta, which is an arching vessel going right across and coming from the right ventricle. I do not know left and right, but this is what it appears on the screen. Both the vessels are parallel, and right from the beginning, there is no crossover. And you see the pulmonary artery down there. You see a VST and you see a blue color blood, which is coming from the right ventricle, entering into the pulmonary artery also. So I think first, I would beg to differ on, the case scenario, single view, but, appears to me as it looks like a tetralogy of fellow physiology because you have PS and override of aorta. That's fine. But talking about the basic diagnosis, I think this is DG.
I need some more views.
Yes.
Could be DORV.
Doesn't look like DORV. The aorta, the PA is actually coming straight from the LV. I mean, there is an override of an aorta, and PA is coming simply from the left ventricle. So it's 1.5 vessel coming from the left ventricle. That is what I will put.
But there is a pulmonary stenosis and atresia that you
yes. The management is may not be very different in the pulmonary stenosis and TGA category. And the difficulty of surgery, I mean, is increases. So it becomes more difficult than a simple variety of tetralogy of fallow. So I think that's what I wanted to say.
So, sir, which disorders require a prostaglandin infusion and which don't require? Sir, would you want to just tell us?
Yes, I certainly would like to make a mention because whenever you see a patient as a cardiologist or a fetal medicine specialist, cardiac lesion, you have to look at a couple of things. Number one is what is the cardiac anatomy. Two is what is the physiology, what is going to lead on to. Three, what are the chance of having a problem during the pregnancy itself? Okay, all ductal dependent circulations. Fine, they are ductal dependent in the fetus also. God forbid you give aspirin or NSAIDs and you close the ductus. The same problem probably is going to happen in the fetus itself, which is going to happen when the child is born. Right. So now and third is that you want to answer whether the child would need an immediate attention or a neonate immediate attention in a transition period. Fourth is that is surgery possible? Fifth is one surgery, two surgery, three surgery, and what is the outcome of the surgery? I mean, we have to look in a broader perspective when we are answering any cardiac lesion for that matter. So for your specific answer on requirement of prostaglandin, that means you are talking about a ductal dependent circulation. You know, a ductal dependent circulation where you need a prostaglandin to keep the ductus open till you gear up your OT, gear up your cath lab to do some procedure or something. And very rightly portrayed that you have a couple of cyanotic disorders which can do it. Then you have left or right-sided obstructive lesions, be it pulmonary atresia, be it a hypoplastic left heart on the left side and on the right side. A severe obstructive lesions on either side would probably require a ductus to be present so that the other circulation can be maintained through that. In a severer right-sided, we need the ductus to maintain the pulmonary circulation. In a severe left-sided, like a severe coarctation of aorta or interruption of we have seen patients with severe pulmonary stenosis, simple pulmonary stenosis, nothing else, no VSD, nothing. They also would require prostaglandins to begin with, because as the pulmonary valve is so small, the antegrade flow is little. You need a support of prostaglandin to keep the duct open so that you can actually manage the baby thereafter.
Thank you, sir. So, Dr. Bala Ganesh, just one sentence for each one of them. TOF with absent pulmonary valve, TOF with a good pulmonary artery, TOF with atresia, and TOF with stenosis. Which one has a good prognosis?
TOF with the good pulmonary artery size.
Which is the worst among them?
Absent pulmonary valve is the worst among them because it is usually associated with the significant airway issues. Okay. A lot more are there, but this is the simplest way I can tell.
Yeah, so the for us as fetal medicine, I think that is what we need to take home, and even the obstetrician and the radiologist, that absent pulmonary valve is a very bad prognosis. Atresia is again a bad prognosis. Stenosis can be worked on, and a good pulmonary artery has got the best prognosis. Sir, I'm right?
It's right. Yeah, it's right. As Ratna ma'am said, we can't completely write off everything. In TOF with the pulmonary atresia, in the absence of Dyejar syndrome, the prognosis is excellent. Only thing we have to close the VSD, and the pulmonary artery has to be made artificially. So the child might require 2 to 3 operations, but he can live a normal life. Recently, we have the largest experience, one fetus, 25 years experience. One of them became a doctor recently, 2 years back. So as Ratna ma'am said, every fetus has the right to live in this world. It's up to the parents to decide.
Yes. So we go on to our next case. Chinmay, maybe you can take it from here. We see a small size left ventricle, primigravida 20 weeks.
Okay, so we definitely see disproportionate ventricles there, and the left side is smaller. So how is the outflow tract?
The aorta was
Much narrower.
much narrower, and you can see the valve, which is ecogenic also. So we made a diagnosis of aortic
Aortic
stenosis.
stenosis, yes. So again, one of these, yeah.
Yeah, please.
So this is going to be quite a significant morbidity for the fetus. And more importantly, it can be progressive. So whatever we are seeing right now, and we counsel them based on whatever is the problem right now, but things could worsen as the pregnancy progresses, because there can be, evolving left ventricular dysfunction. And there is that what is that called? Endocardial fibroelastosis. So this is again a condition which will require a lot of counseling to the family. And I'm going to definitely send them to the pediatric cardiologist.
So here definitely we want the cardiologist input as to how do we monitor this, how do we go forward, and when do we deliver them? Dr. UP Singh?
Yeah, these very rightly pointed out that we have an issue of a very small aorta. Smaller pulmonary artery can be managed little better, but smaller aortas, as they extend right up to the descending one, and they are a little difficult and challenging in the surgery. So these patients, and we really do not know eventually, because I didn't see the arch. Could there be interruption of the aortic arch also? And it does look like, though we don't have a VSD, normally it's associated with the VSD. I think there probably is an arch down there, but that's a left pulmonary artery. Anyway, the prognosis remains the same, because the surgery is not going to be easy in this kind of situation. We just need repair of the aorta with the patch, and that's what it is.
So Chinmay, how frequently do you want to monitor this progression? This patient wanted to continue pregnancy.
So she has aortic stenosis with evolving hypoplastic left heart and single umbilical artery. Now, this is actually a very big challenge. And if she wants to continue, and here, I don't know how easy it is for people to look for in utero treatment, but we generally don't have easy access to that. So I think every 3 to 4 weeks, probably we'll like to monitor her. Because she has single umbilical artery, we also want to look at the overall growth of the baby and look at the aortic flows, at the diameters of the aorta, the left ventricular function. And when to deliver is really a challenge, because that has to be, every time we see her also, we will insist that the pediatric cardiologist also sees her like at least once a month. So that decision will come, because we would like to take the pregnancy as close to term as possible. But if the stenosis starts becoming very critical, then we'll have to take decisions of early delivery probably.
Dr.
I really, can I make a sound? I really don't think so. Late in the gestation, it really makes a great difference in the size of the vessel. So it is always preferred that we already have one challenge, that is, hypoplastic left heart, and it's going to be probably converted and would require multiple surgeries in future to manage. And despite that, the prognosis and outcome is not good. And if we prematurely deliver that baby, we would have an issues of relating with the pulmonary problems. So I think later in the gestation, the decision when to deliver, I really don't think so. We need to hurry up to deliver the child, and just in the context that we would probably prevent further deterioration of the cardiac situation. Deterioration happens quite before 30 weeks, and thereafter it's a kind of stable.
So that's a good information, sir, that we try taking it till term as much as possible, not give another problem of prematurity to the child as much as possible. We would go on to the next case. Sir, UP Singh sir, your
Yeah.
comments on this.
Yeah.
Hypoplastic left heart with atresia, the first sequence. The second one is an interrupted aortic arch.
Mhm.
And the third one is a coarctation. Which one will you give a good prognosis? All are aortic lesions.
I think I would start with the worst one. I think the worst one would be hypoplastic left ventricle, because I'm going to land up with not only single surgery, 2 or 3 surgeries, and thereafter also, each surgery, there's a lot of drop. There is a lot of improvement in hypoplastic left heart surgery these days. We have the survivals which have drastically improved, but still minimum 3 surgeries. And then you end up with a single ventricle kind of a situation, which is not a mortality issue, the issue of, quality of life. Okay.
Yes.
So that's probably puts us the worst, and interruption would be the next. And third one would be a coarctation of aorta. I would probably put it in that sense.
Yes, sir.
Dr. Balaganesh, in case you want to add something?
Yeah, the very good prognosis is coarctation of aorta. In interrupted aortic arch with VSD, there are 3 types are there. Type 1 interruption in the absence of genetic abnormality carries a very good prognosis. Type B is highly associated with the Dijah syndrome. 80% of them are associated with the Dijah syndrome. And type C is always associated with the complex cardiac abnormality. So the only difference between coarctation of aorta and interrupted aortic arch with the VSD surgery is in coarctation of aorta, there is a significant cosmetic role. And the sternum incision can be avoided. Posterior thoracotomy, they will do the surgery, so they can have a cosmetic benefit also. But in interrupted aortic arch with VSD, then they have to do sternotomy, so a big scar will be there. So these are all the small things, but that is very important for the parental aspect.
Absolutely.
Good
Good
point.
point.
With a VSD. Very good point.
Good point.
UP Singh sir,
Yep.
this is a 4th chamber of the heart. Which do you think there is any problem in this heart, in the 4th chamber view?
Yeah, I think there looks like a VSD, and fossa vallis is kind of bobbing on left and right side. It's not looking too healthy. Fossa vallis is not consistently bulging on the left side.
So why is there no flow across the mitral valve?
Okay.
So that is what brought
So
us
I
to
think,
this. Color
yes.
is very important.
Yes, you need to have a proper settings. I don't know, because see they can't be, it can't be possible. You have a mitral valve which is opening.
Yes.
I mean, 2 things are inconsistent. You have something opening, and that is opening, twice in one cycle. That means E and A are there.
Yes.
So
the
some gain
aorta
settings
has
or
got
something
color.
there.
Aorta is good, and the pulmonary artery is also good.
Yeah.
And I have more views.
Yeah, I think there's some flow settings which is there. And, I have seen this kind of patient before. I was given a task of reviewing a patient which had a fossa vallis shifted only to right. That was the only finding. Fossa vallis shifted to the right side. It cannot. It cannot. That means the LA pressures are high. And then it turned out to be, having a mitral stenosis. Okay. So this, even if the mitral valve is looking healthy and good, the low flow on the left side, you give me a caution that there could be a problem on the left side. Okay. Either there's a problem ahead, the aortic valve is not opening well, or there is some issue with the mitral valve. So I think there is some issue with the mitral valve.
Probably with the aortic valve, I think.
Yeah, aortic valve, maybe. Yeah.
So that's this was just to bring about that color is so important. Even if you have everything looking quite well on your 4th chamber view, you need to put on colors and the color in the right settings. So
Fossa vallis in 2D gives you a good clue that something is going wrong, actually. I mean, it can't happen with VSD. It can't happen with anything else. It has to be something related with the LV inflow, something where LA is not is having more pressure.
So Alok sir, we are on the next case, primary gravida or low risk. And at 19 weeks, that is the video that we are seeing. Tricuspid valve is having a huge regurgitation.
Correct. So we are seeing, first of all, we are seeing cardiomegaly. The heart is quite big and it is occupying more than 1/3 of the chest. And the right atrium appears quite large, and there is a lot of tricuspid regurgitation which is happening. And in these cases, we need to see the offset of the tricuspid valve, how far it is from the mitral valve. And if it is more apically inserted, then it is, we call it Epstein's anomaly. Or if it is normally inserted, it's probably tricuspid dysplasia.
Dr. UP Singh, what else do you want to know from the ultrasound for these
Lots.
cases with Epstein or tricuspid dysplasia?
First from the fetal echo, I would like to see the right ventricular outflow tract and its flow. And secondly, I do see some calcification in the area of the tricuspid valve. So I think, as rightly pointed out, I probably would put more money on dysplastic tricuspid valve than on anything else, because you see something. The valve is not looking healthy and okay, right? So that's one thing. So in relation to that, we, as this is a tricuspid dysplasia and Epstein, we need to do a detailed genetic workup apart from anything else.
So Chinmay, I'm back with you. How will we speak to the parents? What counseling we need to do? Do we do a genetic test in tricuspid dysplasia with Epstein?
Well, in many cases, it is like it's a major cardiac abnormality. So definitely we have to counsel the parents that we are looking at some form of treatment later on, and there will be suboptimal function. There could be, evolving problems in the same pregnancy before birth only. There could be signs of cardiac failure. So genetic testing, because we do it in all cardiac abnormalities, we will do it here also. It'll be like a microarray that I will offer them in this case. And if that is normal, then follow up with close coordination with the pediatric cardiologist. Now, let me tell you very frankly here that the reason we keep on bugging the cardiologist here is also for some support that we need in the antenatal period. Because although your role will come only after the birth of the child, in very many of these cases, there may be antenatal, sort of deterioration of the situation, so that it may not actually reach the neonatal period in the way that you have imagined it to be in the first place. So what helps us is joint counseling every time and a joint review every time. Because parents want the best for their child and we also want the best, but nature sometimes does not support us. So we keep calling the patient back every 3-4 weeks, reviewing the situation. And if things don't go the way we have planned, for them to know that we did whatever we could do best under those circumstances. So with that, we will continue and try to take the patient as much as possible to term, so that we can hand you over the baby in a better condition.
So Dr. Bala Ganesh, how is the prognosis and what will it depend on when we give off the baby to you with the tricuspid dysplasia?
It's depend upon the degree of tricuspid valve regurgitation and the gestational age. At 19 weeks, this much severe TR, the chance of developing heart failure is more in utero. So the prognosis is usually bad. If this kind of, if there is some mild to moderate regurgitation, if I see a fetus at the 34 weeks of gestation, I will motivate them to deliver. And it's everything depending upon the pulmonary vascular resistance. Now the pulmonary vascular resistance in utero will be very more, so the TR will get augmented. After delivery, once the pulmonary vascular resistance come down, we'll usually support with the sildenafil or nitric oxide. I have seen many babies postnatally with a mild to moderate tricuspid regurgitation. The TR intensity will reduce over a period of time, and they can have a mild tricuspid valve regurgitation at 6 months to 1 year follow-up. But certain fetuses, if they escape severe TR during the fetal period and delivering in a very sick state, after stabilization of the heart failure and management of the pulmonary vascular resistance, with the supported treatment, we will try to push them to more towards 1 or 2 years, and the tricuspid valve repair can be done also. So it's all depending upon the what gestation and in utero progression that will decide the prognosis, especially in tricuspidal dysplasia.
Thank you so much. So we go on to the next case. Chinmay, I think this is your case. You need to answer me because there is a twin pregnancy. One of the baby is completely normal. At 17 weeks, both were normal. But at around 22 weeks, I see this white echogenic mass. So how will you counsel? This is a rhabdomyoma, which was not there at 17 weeks and has come up as at 22 weeks. It's an IVF conception. Why did we not diagnose it early?
No, you may not have seen it earlier because it may not have been there in this size, and this could have progressed in the intervening period. So if you have as good pictures as you have shown me, the 17-week pictures, that itself is, evidence enough to say that there was no lesion in the ventricle at that point of this
So
size.
the need for images to be there, as what Ramurthy
To be
said.
stored, absolutely. And for us to know that there are conditions that will develop, and once they do develop, and this is at least 22 weeks, many rhabdomyomas actually are seen in the 3rd trimester for the first time. So once we see a rhabdomyoma, the first thing that strikes us is how is it affecting the function of the heart, and where is its location? Because this is a very conveniently posed location of the rhabdomyoma, where it's not actually affecting either the capacity of that ventricle or the outflow tracts. But if it is anywhere close to the outflow tracts, it can cause a lot of functional disturbance. Apart from that, as you have shown here very rightly, the next thing that comes to our mind is its genetic association, because there's a 50% association with tuberous sclerosis. So once we see this, we have to offer genetic testing for tuberous sclerosis. And the situation in your case is complicated because it's a dichorionic diamniotic twin pregnancy. So you have to actually test both the twins technically, because that's the dictum whenever we do invasive testing in multiple pregnancy. So we do an invasive testing and look for the association with the condition. As you have already shown, I'm presuming this was detected in that particular fetus. And is this the same fetus after some time?
Yeah, that's the same fetus. And
now multiple rhabdomyomas all over the heart,
Mm.
and tuberous sclerosis positive. So tuberous sclerosis is autosomal dominant, and with this multiple rhabdomyomas, we know that this child is affected with tuberous sclerosis. Phenotypically, the presentation can be varied, but with so many evolving rhabdomyomas, I like to look at the brain and look for any tubercles that we can see on the brain. And if we see something like that, the prognosis in our minds is a little guarded. And I'm going to refer to Ratna ma'am after this.
So first with UP Singh sir and then Ratna ma'am. UP Singh sir.
I think this is very rapidly grown lesions, and TSC2 is more likely to do that than TSC1, but that really doesn't matter that which one has a more worse prognosis. We wish and hope that these lesions would, that's what the counseling is going to be, would regress as the child grows, out of the hormones of the pregnancy. They do tend to regress. In case they don't, we still have a couple of medicines to do that. Sirolimus or everolimus are the medications which we can use, and even intra-pregnancy they have been tried, but there's a bit of a caution there, but we can still use it there also for a regression in case they are compressing any of the chambers, either inflow or an outflow. For just ugly looking tumors, I don't think so we need any drug, because they would settle of their own. More important than the issues are neurological and other systems. That is something which is more important, and intractable epilepsy is something which is very bothersome. So that is main issue, rather than issue in the cardiology or a cardiac side.
So Ratnapuri madam, can you take us through? We've got one baby who's got tuberous sclerosis. What do we do for the rest?
Okay, so
Do we
the
test
tuberous,
the
yeah. First we'll examine. So we are forgetting to examine. Anna, we shouldn't go straight for testing. So it is a neurocutaneous syndrome, again, extensively phenotypically very, very heterogeneous. So you can have in the same family a father with only a parent with only the cutaneous features and no neurological phenotype, and maybe two affected children, one again with only the cutaneous features and the second with only the neurological features. So again, the challenges in counseling are immense. But once you have a rhabdomyoma, I think you start whilst you're waiting for your mutation report to come. You have to examine the parents. And that's the standard where you look for you see, sometimes the cutaneous lesions are so innocuous that they may not come to attention by the parent, by the person themselves. So you look for all the cutaneous stigma of TSC, and otherwise you do an ultrasound to look for the renal lesions, which may not be picked up in the absence of an ultrasound. And they also suggest that you do a CT scan to look for the cortical tubers. Because if any of these are present, then you're sure that one parent has tuberous sclerosis. About 80% of antenatal rhabdomyomas are because of tuberous sclerosis. And there are two genes that can cause the disease phenotype. The presentation of either gene is not different. The TSC2 gene is much more common than the TSC1. So, in the previous days, if we had to we didn't have the NGS to test for all the genes, we would first test the TSC2 gene and then the TSC1. And whilst about, I think, 80 to 85% or maybe 90% of the mutations are identified by sequencing, there are deletions and duplications, copy number changes in these genes, which would require a different technology, MLPA. We use MLPA to identify those. So you have to finish that entire thing before you say that the rhabdomyoma is because of tuberous sclerosis or it's just an isolated malformation.
So this patient, we tested one of the child, the one which had rhabdomyoma, because the risk of amniocentesis of two babies, they didn't want to take it. And then we tested the parents and the sibling after birth. And all of them did not have the TSC2 gene, which was there in the fetus. So now, madam, what will be the recurrence for their next pregnancy if they want to?
It's not a lot. It's about 1 to 2% because of gonadal mosaicism, but you would still test. But I would do an amnio at 17 weeks to test versus a CVS. If the recurrence was higher at 50%, I would do a CVS.
Yes. So we come to the last case. This is again a first trimester, basically a 14 to 15 weeks in normal NT. And there was hand which had a radial ray-like aplasia. So maybe Alok sir, can you take me through the abnormalities? There's a cardiac abnormality and there's a hand which is appearing like a absent radius.
Yes, so whenever we have a hand-heart abnormality, so the first thing that comes to our mind is trisomy 18. That is the first abnormality that comes to our mind. Then there can be other syndromes like Holt-Oram syndrome and other cardio hand-heart syndromes. But these are rarer compared to trisomy 18 and 13. These are commoner abnormalities that can happen.
So Ratnapuri madam, back to you. What test should I send for this baby who has a single outflow tract, cardiac abnormality, normal NT, and radial ray aplasia?
Okay, so in this case, really, I think, of course, you could have Holt-Oram. Again, you would examine the parents. You would want to look for a triphalangeal thumb, look for one limb which is slightly shorter, which never came to attention, and look for a cardiac defect, because Holt-Oram is autosomal dominant again with variable penetrance. And so if you find something, you know exactly what to test. Otherwise, there's a huge differential diagnosis for this. And it also includes the whole group of Fanconi anemia. And then I would want to do an amniocentesis and do the Brackett studies if I'm sure that it's not a Holt-Oram, which is the easiest thing to identify. If it's Holt-Oram, you just do NGS and look for the gene change. But if it's not Holt-Oram on clinical evaluation, I would want to do the Brackett study, because remember, even if you do a next generation sequencing and you get a variant of unknown significance, if you've got breakages in your chromosomes, when you do the karyotype, the stress cytogenetics, what we call, it's like a functional validation for that variant of unknown significance. So I think that becomes relevant in this situation.
So the learning point here is from this case and the previous, look at the parents. That's what you said. Even for the first one also, look at the parents. And here also the father had a triradiate thumb and so was found to have the TBX5 mutation. And so this was an heart-hand syndrome. And so cardiac association with other abnormalities, you need to test them. So I think maybe, do we have time or do we just close down?
Maybe
Bimal, sir?
Yeah, maybe one last case, because a lot of questions to be asked to the panelists also.
Yes. Yeah.
So last, primary gravida, again, low risk, just to say that all these cardiac abnormalities were in low risk population. So UP Singh, sir, I think you can take this forward.
Please. Okay, so for chamber view again, I think we have parallel vessels and arching vessel coming from the right side. That's what on a quick scan I could see. Then you have in the right atrium what we call as a prominent eustachian valve. It's giving a Y-shaped structure. And this we've seen many commonly. It confuses a lot of people. And many of them would make a diagnosis of quadratum dexter, but that's not what it is. So on the second video also, I see the right ventricle leading to the large arching vessel, and then so we definitely need color, you know.
So, sir, we will get into the color area, but
Yeah.
transposition of great vessels.
Yes.
How do you prognosticate? What are the types of TGAs? And do we always have a VST in these abnormalities?
More than not, we don't have a VST. VST does happen in about 40 to 50% of the patients. And VSD, you know, makes me a little happy if I'm seeing a fetus with a TGA, because I know that I'm not going to have a rough time in the transition period. VSD would work like prostaglandin-induced ductus open. At least I have some shunt. I don't have to run around to find a balloon atrial septostomy there. So a presence of VSD, you know, in this situation makes me a little happy. But we commonly don't have a VSD, and then that is where the situation is a common garden variety of a TGA, where if the interatrial septum, if it does not behave well, and it closes during you know, that transition period, and that's the time when there is no mixing between the right side and the left side of the circulation, and you have to create a mixing for the oxygenation and stuff to happen, and you immediately might need to do one is keep the ductus open, and secondly do a balloon atrial balloon atrial valvoplasty, or that ballooning of the opening of creating another ASD is more important than just having patent ductus, because that is where circulation. There are so many variants in TGA. A lot of things are happening in this area. People are trying to look at the patterns of fossa ovalis, which has some prognostic implication. They are trying to look for the flow in the ductus. If you see the flow in the ductus, a normal one-sided flow is okay. And in case you have a bidirectional flow, again, these are important markers for prognosis.
So, but otherwise, it's a diagnosis which you will tell the patient it's good to continue.
I think this is one of the correctable conditions, particularly in case there is the chambers are both fine and there is no significant pulmonary stenosis associated with. I mean, the surgery is okay and gives a very good outlook. Post surgery, the follow-up is there, but most of them would not require a significant intervention a second time in their life.
Dr. Ratnapuri, do we do a genetic test in this?
So whilst transposition of great vessels does not have a great association, but I think that if the pregnancy is being continued and there's a malformation, it's worth its while to do a chromosomal microarray, at least just that, no exomes.
So association is less with genetic abnormalities, and it's a disorder which has a good prognosis. So Chinmay, any plan of management for this patient at term? Where do we deliver her? What all specialists do you require for this baby?
No, like UP Singh sir said, if there is a VSD, then it is always an easier way to counsel them that there may not be an immediate neonatal problem. But in these patients should be delivered in a center with a good tertiary level neonatal backup. And they might require an immediate cardiac intervention to keep the flows going on both the sides. So she should be delivered in a tertiary level center. The mode of delivery in any of the cardiac diseases actually is not recommended to be a cesarean section. The mode of delivery should be vaginal as far as possible. In fact, there is a paper that was published in 2022 only in Pregnancy and Childbirth, where they said that despite all the efforts, the incidence of operative vaginal delivery may increase, because some of these cases you get a little worked up when you do fetal heart assessment in labor. But there is no recommendation to do elective cesarean section, and cesarean section should only be restricted to obstetric indications. And the plan should be to affect a vaginal delivery, but there should be a backup of a senior neonatologist available at the time of delivery, because there will be requirement of support and prostaglandin infusion. And if necessary, like sir said, there might be a need to do a balloon septostomy as a palliative procedure till a definitive surgery is done. So to image this abnormality is quite nice, and to define the abnormality is quite nice. But the outcome really depends on good neonatal management and a proper follow-up thereafter.
I want to make a small comment before we actually disperse that. It is good to have, vaginal delivery, and, the complication rates are less, agreed. But, imagine another scenario. You planned surgery at, 1 p.m. when the cardiologist is standing right in your OT, when these facilities are not available everywhere in India. They are even in government hospitals, you would have a very patchy kind of manpower available when you actually need all that. Half of the labs are not. So I think maybe I would probably would think that, okay, doing a planned timing of delivery where a lot of professionals are involved may not be a really bad idea.
So that is actually the practical reality, what you are talking. And that's, a lot of us have to agree that sometimes we have to give in to those pressures. But as a general message, sir, the whole idea is some center should develop that expertise and should develop teams, so that, round the clock, there are people to cater for these situations. And that would be ideal. Well, that would be ideal if we would be able to, promise a mother that we won't intervene just because we cannot make all of us available at the same time.
Absolutely.
But, practically speaking, I agree. It's a one-to-one decision.
I think let us stop here, and I give it over to Dr. Bimal Sahni. We finished all our cases, and thank you for giving us an extra time. So thanks all the panelists for such an interesting panel discussions. We were able to finish off all our cases, which were not given to any one of them. They are all extempore. And I would thank Dr. Bimal Sahni and Dr. Ashok Khurana for letting us do this panel. Sir, over to you.
Very much, Vandana. That was wonderful, and really thank all the panelists for their wonderful inputs. I have a question for Dr. Balaganesh. He's there. See, your setup has, it's been doing a lot of work on postnatal management of TGAs, a lot,
Yes,
and
sir, yes, sir.
with very good success rates.
Yes,
I just
sir.
wanted to know, yes, in most of the cases, the outcomes are good. So whenever you found that the outcomes were not good, what were the reasons behind that? Was it, due to some, are there some poor prognosticators which would
Yes, sir.
to...
Everything is based on the foramen oval, sir. If it is restrictive, the child will crash within half an hour to 1 hour after birth. So the only TGA can be easily diagnosed by anyone in utero. The only role for fetal cardiologist to assess whether the foramen oval is restrictive or not. That can be easily assessed by putting a Doppler in the pulmonary vein. If the pulmonary venous velocity is very high, that is indicative of restrictive foramen oval. That is one of the definite indication for lower cesarean section. Because if the second stage of pregnancy is prolonged, there is high risk of hemodynamic compromise will be there. So if TGA has been diagnosed, then definitely has to be delivered in a cardiac center. A neonatologist as well as a pediatric cardiologist should be there. These babies will need immediate intubation after initial resuscitation. And if the foramen oval is restrictive, there is no question, straight away from delivery room to cath lab for balloon-atrial septostomy. We usually do TGA surgeries at day 3 of life with a very good outcome. And it's based how if it is the surgery is done very early, the outcome is very good. Long-term complications like suture-related outflow tract obstructions are very less. So TGA-wise, the genetic association is very less. It has a very good, excellent prognosis. Has to be delivered in a cardiac center, and balloon-atrial septostomy can be decided. Nowadays, we won't do balloon-atrial septostomy. Only rarely we see foramen oval restriction. If it is there, it is if the fetus delivery anywhere else, definitely it will die, because transport-related risk is very huge. In restricted foramen oval, the prostaglandin is contraindicated. We should not use prostaglandin in TGA with restrictive foramen oval. So that will add up to the increased pulmonary blood flow. So small things are there, yeah.
This transport-related issues. Now, there may be a time, some cases where, yes, they still have to be transported. So are there any particular precautions or some messages you would like to give where, if at all the baby has to be transported, these are the things that you need to take care of?
Yeah, as UP Singh sir told, if VSG is there, then the transport will be very safe. The baby won't crash that too much. The critical fact is foramen oval. If it is restrictive, that is the only pathway that cardiac output will be delivered to the baby. So if it is restrictive, immediate balloon-atrial septostomy is there. If that is not the case, there is no way. We have to start the prostaglandin and immediately shoot to the cardiac center. When I was a resident, we used to go to the center and do bedside septostomy through the umbilical vein and the transport to the. My thesis is transport only. I shared the link in the chat box. So transport is the key.
And what about, because see, for a common man, AVSD becomes a very big cardiac disease. Now, isolated, balanced, complete AVSD, surgical results. Okay, no, genetic screening done, genetic testing done, everything else is normal, no extra cardiac anomalies.
Yes, sir. 3 things I will look, sir. One is in utero AVL regurgitation, and all the 5 leaflet has to be assessed, and balanced ventricles. These are the 3 very important things we should look at. If everything is fine, there is only trivial AVL regurgitation. In the absence of genetics, it's dependent upon the surgeon who is operating. Even though the surgery is very successful, the left AVL leakage is unavoidable, even with expert hands. So the overall long-term outcome, 20-year survival is 86 to 91%, 40-year survival is 78%. So it's depending upon the surgeon and it's depending upon the anatomy, especially the mural leaflet. That is the leaflet which is very important for surgical correction. And that will decide the overall outcome. And also, as well as the risk of heart block, surgery-related heart block is more in complete AV canal repair. These two things will decide the long-term outcome.
Can I ask a question, Dr. Balaganesh?
Yes, ma'am. Yes, ma'am.
You have a very good setup with a lot of state support for surgery and a lot of experience. Do some of your cardiac problems still get terminated?
Yes, ma'am. So I see three groups of people, ma'am. Group one, they want everything to be normal. Even LSCC, they will terminate. Even echogenic focus, they will terminate. The second group is the most interesting group. I like them very much. They will ask only two questions. I need financial support. If the lesion is corrected with a single stage surgery, I will go ahead. That's the only thing which we are doing. We have a good non-governmental organization which is helping. Whatever may be the surgery which is easily corrected with a single stage surgery, with 30 to 40,000, everything can be cured off. So those, in the absence of genetics and extra cardiac anomalies, I'm talking about. Third set of group, whatever you tell, it's a God's gift. Whatever is the possible way, you just help them. Yeah. That is the role for fetal cardiologist. There is a particular community there. These three groups are there. Depending upon the group, my counseling will start in that way. So finance is not a burden. My practice is in Tamil Nadu. I am a visiting consultant in Kerala. So I am working in a secondary level setup. So even duct dependent circulation in a secondary level setup, in the presence of a pediatric cardiologist, we can deliver easily, especially in coarctation of aorta and all. We can deliver easily in a secondary level setup. We don't know, out of 100 screening, 99 will be normal in coax suspicion. Only one will turn out to be coarctation of aorta after the PDA is getting closed. So here, overall, based upon the counseling, the parents will decide. 80% of the parents will go to the pregnancy. I will force to terminate certain groups of disease, heterotaxis, hypoplastic left heart, single ventricle physiology, two ventricles with complex intracardiac anatomy, and those things I will ask them to terminate. But the only thing is the fetal cardiologist has to take some challenging risk. I will tell one example. Corrected TGA with the intact ventricular septum, which usually carries a very good natural history. This is second gravida. They definitely wanted the child if the long-term outcome is good. As per literature, only during the third and the fourth decade after birth, they can have a tricuspid-related regurgitation and left-sided systemic ventricular failure. I counsel them in the same way, and there is a small chance that they can develop in utero also. I assess the fetus at 22 weeks of gestation and corrected TGA intact ventricular septum, only mild tricuspidal regurgitation. When I am assessing at 34 weeks of gestation, there is epsilon malformation of the tricuspid valve, severe tricuspidal regurgitation. I don't know what to say. The obstetrician asked me very clearly, sir, whether I should deliver in my center or you have to deliver in the Amrita hospital. Then I told them, ma'am, corrected TGA intact ventricular septum, we can deliver safely in your hospital. Within 1 week, she called me back. The fetus had supraventricular tachycardia, fetal height drop, severe AV valve regurgitation, and postnatally delivered. The fetus had coarctation of aorta. Coarctation of aorta. That is very, very unusually. Postnatally, I reported one cases. Fetally, this is the first time in the world I am seeing that. What should I tell? I can't tell anything. I have to take the risk. And there are certain situations they will mimic like hypoplastic left heart syndrome, especially redundant foraminal flap aneurysm with the bilateral superior vena cava. Exactly, they will present like hypoplastic left heart syndrome, but it's a very transient phenomenon. So we have to bite the bullet and take the risk. It's very easy to say termination, but I will tell them in such a way that they can continue the pregnancy. I have a lot of case series in that the good result. They can have a normal life without any intervention. So it's a challenging thing.
Just one comment. Dr.
ma'am.
Bala Ganesh has got 20 publication in international in past 2 years. That is how he is working with the amount of academics he has. He sent me a CV and there are 20 publications which are written in his CV in the past 2 years itself, international, all of them. So I think it's a clap
Thank
for
you,
all.
ma'am.
Commendable. And no, and I think one of the other important points that you brought across, like you are a really ace cardiologist and you work with apex institutions, and despite that, you see the clinical picture was changing.
Yes, ma'am. Yes, ma'am.
And this is something which most other practitioners get a little thrown away when they have these kind of surprises, because every cardiac lesion, although there is a paragraph written about it in the textbook, it doesn't follow that paragraph all the time.
Exactly. This is absolutely true, ma'am. That are based on the Western literature. Those days we are sparsely seeing some fetal cases. Now we are expert in everything. We do see a lot of cases than the Western literature. So they have a system in place and do all the measurements, everything in place. So they are speaking in a big stage. If we do, we will rule them in every aspect. These things I learned from my guru, Balu sir and Krishna Kumar sir. They are the big shots in everything. So I'm just starting. That's it. They are giants and legends in this field. I'm
You're
blessed to work with.
extraordinarily well, and we are also proud of you. And I'm sure you'll take the flag much higher than where it is. Thank you so much. Over to Bimal sir.
I think one of the reasons why patients opt for termination in most of the cases is lack of information which is provided to them. In
Yes, sir.
fact, forget the patient. Even we as imaging people or the obstetricians per se, anything hard, nobody wants to put their foot in and say, okay, this could still do well. Anything, because for a patient, a small VSD or a very, very complex cardiac anomaly is one and the same. This is a cardiac anomaly. So I think at the primary level, whoever has picked it up also, without being aware about how these results are, should not give a very, very negative, image about this whole thing. And maybe, if the facilities are not available, consult with someone. And at times, if you give them this information that, yes, this is possible, these are the centers which do it, you can go there, you can consult someone before you take a call, then quite a few of them do decide to continue with their pregnancies. But if we have pre-decided, because the majority of the time we say, but this patient will not afford, they will not do anything, they'll never, because we just take it for granted that. But if you give them a chance, you tell them everything. I've seen in my own practice that yes, quite a few of them have thought positively about it. They consulted people. They consulted even the pediatric surgeons in Bangalore. They went to Bangalore and delivered there. So all these things people did. I think it's all about providing the information. So every time you see a cardiac defect, should not be we should not portray a very, very negative future for that. We just give them the correct information, and I think most quite a few of them would really do well. And as UP Singh sir also said, there are so much of improvement which has happened in cardiac surgery. And
cost is a very important factor. I think
cost is so that's what you let them know everything. A fetus in the womb is much better than 3 in the waiting.
True, very true.
In today's era, so you give them the chance, and especially with all this ART and all those things, give them the chance, and they would probably want to continue with that pregnancy. Sir, last words.
Well, it's been an absolutely charming evening, if I may call it that. We set out to keep up this concept of being aware, and we have achieved over the last so many years a lot of things. The first thing we've achieved is the fact that we realize that we need to learn. We also realize that we are going to keep on learning continuously. We realize that we're living in a changing world where genetics will change, and that will change the prognosis and management, where technology will change in terms of imaging, and that will change the prognosis and management. We've learned that an interdisciplinary and multidisciplinary approach is something that is indispensable, and that the first word by the first person who discovers the lesion, as Dr. Bimal Sahni has just pointed out, is going to decide whether we are going to murder or we are not. And I use the word murder for the very simple reason that we are judgmental, which we should not be. We must let the patient know that these are the options. And that takes us to step number 1. Step number 2 is that most people will terminate because they feel they cannot afford the cost of investigations. At Society of Fetal Medicine, we have bargained with industry to make sure that there are 3 things that are available now at almost like a zero cost. One is that those patients who need free genetics investigations can be guided to private companies, which are now working on projects with us to ensure that these are available at almost a zero cost in terms of genetic evaluation, stepwise, of course, that we start with the QF-PCR, if that's the first test or a FISH, and then we go on to a microarray or a gene panel, depending on what is appropriate. The second thing that we have started is to ensure that autopsies are becoming increasingly available and that these do not cost much. And this, again, is a project that we have taken up with the private sector. And it's an ongoing project. And the good thing is it serves as a clinical facility as well as gathering data that, yes, indeed, it is useful even in our scenario. So that will look after this little gap that we've had in terms of cost. So cost really is not a consideration anymore. The third thing where you and me have to struggle the most is to make sure that the government at the center and the government at the state level understands the responsibility to make facilities available, such as we have seen in Kerala, and realize that that is the model that will work. And that if we are to give every fetus a chance and every human being a chance to survive, after all, the fetus is a human being, then we have to convince them that this is where money will be well spent. That is something where we really need to sensitize. We need to make sure that we channelize NGOs. A lot of them are currently completely out of business because they're not getting any money anymore, but they can get it even for programs like this, where the money does not necessarily have to come from outside the country. So that is the path that we still have to tread. But it's fantastic how we've navigated this road today. We started with a basic introduction and then 2 spectacular lectures. Thank you, Bimal, and thank you, Dr. Ramamurthy, for those. And then we had an excellent panel that has sensitized at least initially the 250 of us who have been on this program, and then hopefully through social media as well as YouTube, the SFM YouTube channel, something that all of us can refer to at all times. And we've had an absolutely fabulous panel discussion. Thank you, Dr. Vandana Bansal, and all the panelists for that. And I think it's late night, and we sleep with a lot of hope tonight because we have achieved what we set out to do. Yes, there's a long road ahead, but thank you, Bimal, for initiating this idea and for putting it in place. This whole idea was really Dr. Bimal Sani's idea, that it's awareness, it's something that is our social responsibility, and we will live up to it. Thank you indeed, each one of you, for a fabulous program. And I look forward to a fulfilling year ahead, trying to meet all that we have discussed, trying to meet the needs that we have discussed today. Thank you very much.
Thank you.
Thank you, sir.
Thanks.
Thank you. Good night.
Good night.
Good night.
Good night, sir.
Night.